So we sort of have this, kind of a good cop, bad cop kind of thing perhaps going on. I don't know how far that will go, but some of us are sort of grim. Diabetes will kill you. Take better care of yourself. And you can do it. And other people, oh, you can do this. And so Greg and I are more the, you're in trouble, kind of bad cop group. So Greg, I first met Greg flipping in the old-fashioned days before digital radiology. We'd trot in and to the radiology department as interns with a bunch of cut film under our arm. These things are kind of big. And we'd go in and we'd put them up on the reading board and we'd ask somebody who knew more than we did, which is usually almost anybody, janitor, kitchen help, what's this x-ray show? And hopefully we'd find somebody like Dr. Blair to help us out. And so he was, one of my first memories here was trotting in with x-rays where I had no idea what I was looking at, and having Greg patiently walk me through how you read an x-ray. So Dr. Blair got his medical degree from the University of Utah and completed his residency and his specialty training in pulmonary and critical care medicine at University of California, Irvine. And so he's board certified in all kinds of things, internal medicine and pulmonary care and critical care and sleep medicine. So he's got a lot more letters after his name than some of us do. But a lot of his life he spent in the intensive care unit, which I think is kind of where we're going to hear from him hopefully now to kind of give some sense as to where things go with diabetes and why we should care so much about it as individuals and as a culture. Because I would argue that in a sense, big pharma and big food are letting us down. And the only people that can change that are people like us, I would submit. And I think it's easier than we think. So Dr. Blair, would you take over? Because I'm getting kind of nervous.
So before I start, I'd like to give you a little bit of advice. As an intensivist, I had lots of things to worry about, and I worried constantly. And I found that a lot of the things I worried about never came to pass. And so I really needed to learn how to worry efficiently. And so I found one way to worry efficiently, and I'll kind of describe it to you. So right now, you really only have two things you need to worry about. Am I healthy or am I sick? If you're healthy, you have nothing to worry about. If you're sick, you have two things to worry about. Will I get better or will I get sicker? If you get better, you have nothing to worry about. If you get sicker, you have two things to worry about. Will I be cured or will I die? If you're cured, you're fine. You have nothing to worry about. If you die, you have two things to worry about. Will I go to heaven or will I go to hell? If you go to heaven, you have nothing to worry about. If you go to hell, you have two things to worry about. Will I end up original or will I end up crispy? So I hope that helps you to kind of consolidate your worries and think about the things that are important. So to start out with, I've had over 40 years of experience in critical care, and I'm also board certified in internal medicine, sleep medicine, pulmonary medicine, and critical care medicine. And so I'd say the first half of my practice, it's always been about half inpatient, half outpatient. And with my outpatient practice, it was probably the first half was mainly characterized by taking care of people that were sedentary and smoked too much. They'd get referred to my office and I would take care of their COPD, their sleep apnea, or their chronic respiratory failure, their lung cancer. And I'd say the last part of my practice was mainly taking care of people that were sedentary and ate too much. And I would take care of their sleep apnea. And so really my whole practice has been taking care of people who don't take care of themselves. And I found that in patients with type 2 diabetes, they had a lot in common with patients with sleep apnea. Most of them had, they had caused their own disease, and they had a curable disease. And it was just trying to convince them that they should do the right thing and cure their disease. Interestingly enough, being in the ICU, most of the problems that we saw when patients were admitted to the ICU with type 2 diabetes wasn't due to their diabetes per se, their high blood sugars, but rather from the ravages that their diabetes had done to their other organ systems over the years. In short, it made them frail. So when they were faced with an illness or a disease, they were unable to deal with that effectively. As far as being admitted to the ICU, I can absolutely assure you that for most people, that is the worst day of their life. They are critically ill, they're anxious, they're short of breath, they're often in pain, they're attached to a bunch of monitors, IVs are placed, medications are given, multiple tests are done. It is a horrible experience. And if you can convince your patients of how horrible this experience is, you may be able to convince them to take care of themselves to avoid ever having to experience this. The other thing is that it's not just the patient that suffers, it's also the family. And so you've got the family who has a loved one in a critical care unit who's trying to die, and they're very anxious, they're upset, often the family becomes dysfunctional. To make matters worse, often the patient can't make decisions for themselves. So what we have to do is we have to go out, talk to the family, try to get consent. Does your loved one want to be intubated, put on a ventilator, central line, blood transfusions, surgeries? And probably the worst conversation we have is when we go out and we have to discuss whether we should withdraw care. And so this is all a terrible experience. And I'll go into a little bit more detail to describe what happens. So the reason that patients with type 2 diabetes are more likely to experience a severe illness and end up in the ICU is because of what's happened to their bodies over time from their diabetes. It impairs their immune system. They can get fatty liver disease, something we call NASH. We'll describe that a little bit more. Kidney impairment, cardiovascular disease, poor wound healing, and peripheral vascular disease. All of these make them more fragile. It makes every organ more fragile and more likely that it will be injured during that critical illness. So if we look at the immune system, it's probably best to think of the immune system in a diabetic as being sluggish. It's slow to recognize infections, it's slow to respond, and often responds inadequately to overwhelming infections. in view of this, their infection tends to get much worse. Someone with, say, a urinary tract infection that can be treated with an outpatient antibiotic, with a diabetic, it becomes urosepsis and they end up in the ICU extremely ill. And the other thing is, once they end up in the hospital, they're at more risk of developing a hospital-acquired infection. This is awful because hospital-acquired infections tend to be more aggressive and they are more difficult to treat. They're resistant to multiple antibiotics, and often the drugs we're using to treat them have a lot of organ toxicity. The next is fatty liver disease. If you look at the piece of meat on the right side, this happens to be a grass-fed ribeye steak. It's a wonderful steak. You can see it's got a little bit of marbling and a little bit of fat in it, and it's a wonderful piece of meat. The one on the left is a New York Wagyu steak. And you can see all the marbling and all the fat within that steak. Well, unfortunately, this also happens with humans. So in people that eat too much and the body is overwhelmed by calories that can't metabolize, it starts depositing fat in places where it shouldn't be. In some people that are obese and have type 2 diabetes, their muscles can look exactly like that piece of Wagyu beef. It causes a lot of inflammation, and that can result in some people experiencing chronic fatigue, muscle pain, and we think it may contribute to some people with chronic fatigue syndrome. But more importantly is what it does to the liver. And so it can be deposited in the liver just like that. And when it's deposited in the liver, it causes chronic inflammation and injury of the liver, something we call NASH, or non-alcoholic steatohepatosis. Over time, if this isn't treated and reversed, the liver can end up looking histologically exactly like someone with alcoholic cirrhosis. Well, this is a real dilemma because of the importance of the liver from two perspectives. One is if it's damaged, its impaired ability to metabolize toxins and drugs. So, for example, it's really important in metabolizing things like lactate in lactic acidosis. If normally the liver can metabolize that lactate, then it makes it easier to take care of the patient. If the lactic acidosis is uncontrolled because the liver can't do anything, then it becomes much more difficult to treat. But even worse is the fact that the liver has something called a reticuloendothelial system. What that is the blood vessels in the liver are lined with white blood cells. The white blood cells and the vasculature in the liver is very efficient at removing and destroying bacteria. So if you get a blood infection, you have sepsis, bacteria is in the bloodstream. When it goes through the liver, that liver can be very efficient at removing the bacteria. If that's not there, then we can end up with uncontrolled sepsis and a high death rate. The other thing is diabetes affects the kidneys, and so most people that have had diabetes for a long time have some degree of renal impairment. As long as they stay well and they don't get sick, then it doesn't seem to be much of a problem. But when they become ill, it puts a lot of stress on the kidneys. particularly because they may have blood pressure problems, so we're putting them on medications to maintain their blood pressure, which reduces blood flow to the kidneys. They may be on renal toxic medications like certain antibiotics, which can cause further damage to the kidney. And we know this is happening because as we monitor them, we can see their BUN and creatinine rising and their urinary flow dropping off, and we know that they're starting to go in renal failure. Their kidneys are fragile and they can't deal well with this critical illness. Also, people with diabetes tend to develop an accelerated atherosclerosis. This can result in a number of problems, including, of course, stroke, myocardial infarction, cardiac arrhythmias during these events, but also they develop peripheral vascular disease. And with the peripheral vascular disease, they can lose blood flow to their extremities, to their bowel, causing bowel necrosis, requiring surgeries that they may or may not ever survive. It also creates problems with what we call microvascular disease. So microvascular disease are the small arteries that perfuse the skin, fat, things like that. Well, fat isn't perfused very well anyway. So if they happen to have to undergo surgery, then they have very poor wound healing. And so the surgeon sews the wound back together in 4 or 5 days. Normally in someone without diabetes, the wound's starting to heal, pull together, it looks really good. In people with diabetes, it'll go 4 or 5 days and nothing's happening. And not only is it not healing, it's starting to fall apart. And then the surgeon's faced with a real dilemma. Does he put in these large sutures to try to hold things together, or does he just open up the wound and pack it and hope it heals from the inside out? This, of course, leaves them exposed to more hospital-acquired infections and more complications that can absolutely be devastating. And finally, peripheral neuropathy can also be a problem, not only in inducing the disease, because in many of these individuals, they don't have sensation in their extremities, so they can develop an infection that will progress rapidly before they're even aware that it's happening. So this also applies to even with their hospital stay. Their skin is poorly perfused, they develop a skin breakdown. Our nurses are really good. They're turning these people every couple of hours, watching for skin breakdown. But with the combination of the neuropathy, peripheral vascular disease, often obesity, it makes it very difficult to prevent these types of complications. So the important thing, I think, is trying to avoid an ICU stay. And I'll tell you, I hate to be honest with you, but I'm kind of a cynic. And I'll give you an example. You have someone who comes in, I'd have someone who would come into my office, heavy smoker, can barely walk from the waiting room to the examination room. And they're huffing and puffing and they're still smoking, and I'm going, and we get pulmonary function tests. And at that point, I can very closely predict their future. I can tell them in 2 years you're going to be on oxygen, 2 years later you're going to be dead, you've got to stop smoking now. But unfortunately, physicians are often limited on how much time they have with their patient. And also, after a while, you start feeling like a total Cassandra. You can see the future, you can tell them the future, and they don't believe you. And so sometimes it can get discouraging. And all I can say is don't get discouraged and be a cynic like me. Really pound in how important it is that they potentially have a curable disease. They can prevent all these things from happening by simply do diet, exercise, glucose control, and there's the possibility that if they take good enough care of themselves that they'll no longer even have to worry about glucose control. The most important thing is commitment, and that's where it really gets difficult from my perspective, is getting people to actually commit to taking care of themselves. They spend a lifetime not taking care of themselves, and all of a sudden they have to change their lifestyle and take care of themselves. But it's worth the effort.
Thanks, Greg. How is that for a sobering start? So the next job of the rest of us is to give the answers for how to keep all this from happening. But everything he said is real.
Do we see why this matters? I'm so glad you're here today. Our next speaker is Dr. Von Wolf. Dr. Wolf grew up in Michigan and earned her bachelor's degree in molecular biology from the University of Michigan. She continued her education locally, attending the Medical College of Ohio for medical school before moving to Portland, Oregon for her internal medicine residency and chief residency at Legacy Health Systems. She specializes in endocrinology, and that was pursued through a fellowship at OHSU, where she developed a deep interest in the field due to personal experiences with type 1 diabetes within her family. And I would say she's quite the athlete. You'll hear her talk on Walk, Don't Run to the Doctor. There are a couple episodes with her on it, so make sure you check that out. Dr. Wolf has been practicing as a clinical endocrinologist in Portland for many years, valuing the enduring relationships she builds with her patients, as well as her role in educating future physicians at Providence St. Vincent's right here. And outside of medicine, she enjoys running, traveling, and cooking with her husband and 2 children, making Portland her home for over 2 decades. Please join me in welcoming Von Wolf.
All right, how does this sound? Okay, thank you. All right. Thanks everybody for joining us today and choosing to spend your Saturday morning with us. So we are going to be talking this morning, of course, about this big question: is type 2 diabetes remission reversal possible? Is it real? So when Miles asked me to give this talk, I said yes pretty quickly, because let's face it, I think that's just the effect Miles has on people. But then I got to thinking about it and I thought, oh my gosh, what have I gotten myself into? This is a huge question, right? So this diagnosis that affects 1 in 10 Americans, is it really reversible? Could we be doing something other than spending millions and billions of dollars on medications and ICU care, as we just heard from Dr. Blair? And I will tell you right from the start that I do not have a black and white, one-size-fits-all answer to this question. I'm certainly not harboring any secret treatments that I can release to the world and reverse this horrible crisis that we're in the middle of. I can tell you that, like so many things in life, when you start to pick apart at the layers, we find that it's much more complicated than it appears on the surface. So Miles asked me to give an endocrinologist perspective on this big question. I'm certainly happy to do that. I'm here to play a bit of a devil's advocate, so to speak, and I'm going to outline why, unfortunately, it's not so simple to just eat less and exercise more, and what is behind all of this. I'm going to kind of go through these, I'm going to lay out these challenges, really not to lay out a list of excuses or to make it sound like this is impossible and we should all just give up, because I certainly don't think that's true. But really just to kind of explain more all the complicated factors behind eating less and exercising more, and why this is so difficult. Because if it weren't difficult, if it were easy, people would just do it. Nobody wants to be unhealthy. Nobody wants to be sick. And so if it was as simple as that, people would just be doing it and we wouldn't be in this crisis. So I really just want to help us all understand a bit more what our patients are going through. I will also say that this entire talk that I'm giving is under the agreement and understanding that I think we all have, that it is far preferable to manage diabetes with lifestyle changes as opposed to medications. And that itself, of course, could be an entire talk, but I'm just going to go with that assumption that we all agree with that. So we're going to be talking about our goals, our challenges, and some solutions. I always like to start talks with a few cases. We'll meet these people and then come back to them at the end of the talk. So Robert is 53. He hasn't had labs for a few years, and now he has labs showing that he has diabetes. He has an A1C of 8 and an elevated fasting glucose. Ruby is 64. She's had diabetes for 10 years. She was well controlled initially on metformin, but fairly quickly had to add in a couple of other medications. And now her A1C is 10, despite 3 medications. And Fiona is 42. She's had diabetes for 6 years, well controlled for quite some time on metformin, but now targets are above where we'd like. She's been thinking about another medication, but has not really taken the plunge yet for a second med. She really feels like this could represent a failure on her part. So fortunately, I think our goals and our patients' goals line up pretty well. We want patients to be healthy and happy. They want to be healthy and happy. We'll come back to the happiness piece in a bit. When we're talking about diabetes, of course, we use the A1C as a major metric to assess how well we're succeeding. And we have multiple studies on this, but the landmark trial for type 2 diabetes was the UKPDS, so that was the United Kingdom trial. It was a randomized trial that started in the 70s, was published in the late 90s, and they randomized people to either tight control, which was a fasting glucose of less than, I think it was 115, or standard of care, which at that time was just aiming for a fasting of less than 225. And what they found, the treatment group was randomized to either metformin, sulfonylureas, or insulin, or a combination if they needed more than one therapy. What they found on the bottom left is that with improved A1C control, they saw fewer microvascular disease endpoints. So as Dr. Blair laid out, microvascular disease being the disease affecting the small blood vessels, so the eyes, the kidneys, and the feet. And that was primarily driven by a reduction in the amount of treatments needed for retinopathy, specifically for the eyes. They saw a trend towards a decrease in macrovascular and myocardial infarctions, but it didn't meet statistical significance in the original data set. They also analyzed the impacts of tight blood pressure control and did see significant reductions in macrovascular disease with improved blood pressure control. On the right, we have the 10-year follow-up data. And so this was what first got us thinking about this idea of a legacy effect. So the sooner you can control somebody's blood pressure and blood sugars, that has lasting benefits for decades, really, because we now have 24-year follow-up data showing that even though the original treatment group, after they were out of the study, their control lessened and their A1Cs got worse as the control A1C groups got better, they kind of met in the middle. 10 years later, 24 years later, the people that were in the original tightly controlled group are doing better. So now we talk about the challenges, because again, this becomes a sticking point, because on the surface you think, well, it's that rule of thermodynamics that we learned about. It should be calories in, calories out. We should just be able to eat less and exercise more, and that should take care of this problem. Of course, again, the reality is that it's just not that simple. And so I'm going to lay out the reasons why it's not that simple, why it just doesn't happen. Why aren't people doing this with more frequency? And there's a number of reasons. So genetics plays a huge role. When I see somebody with type 2 diabetes, nearly always there's somebody else in their family who has type 2 diabetes. To the point that if I'm seeing somebody with that diagnosis and we can't find anybody in the family with that diagnosis of type 2, assuming they know their family and their family's getting routine medical care, I actually go looking for other causes of diabetes, because it surprises me if we don't find that. So people get stuck on the genetics piece of it too, because the argument is, well, our diabetes has skyrocketed in the last several decades, last couple of generations. We haven't evolved in that time, or genetics haven't changed, and that's true. I think of this as we do with other disease models, as it requires a second hit. So you have the genetic predisposition to type 2 diabetes, and then it requires something else to unmask, and usually that's environmental, something from a food standpoint or a culture. And we see that, of course, with indigenous populations some indigenous populations are at higher risk for type 2 diabetes than others, and yet they have very low rates of type 2 diabetes in wherever they're from. And then if they move to the United States, the rates of diabetes skyrocket. So of course, their genetics didn't change just with moving across the ocean, but what changed was their environment. Intrauterine exposure to hyperglycemia or gestational diabetes. This is a fascinating one. So what we see is that when somebody's mom has gestational diabetes or type 2, when she's pregnant with them, that greatly increases their risk of diabetes. And we see this with discordant siblings. So what do I mean by that? If you have an older brother and say your mom did not have diabetes when she was pregnant with your older brother, and then say 3 or 4 years later she becomes pregnant with you, and now she does have gestational or type 2 diabetes, your risk of developing type 2 diabetes is going to be 3 times higher than your older brother's. And that's even with the fact that you both grew up in the same household. You were exposed to the same food culture, the same attitudes about eating and exercise. That even holds true if both you and your older brother weigh the same. So it's not even an issue of obesity. It's the issue of the exposure to high blood sugar in utero. We also have really fascinating functional MRI studies. I have the one representative picture here on the right showing that if your mom had hyperglycemia, gestational diabetes or type 2 diabetes when she was pregnant with you, your brain lights up in different ways when exposed to food. And again, we see that with discordant siblings as well, where one sibling had been exposed to that and one had not. So the reward centers in the brain light up differently when you see a picture of food compared to somebody who doesn't have that background. Childhood dietary habits, of course this is huge, and this could be an entire talk just on its own. So familial attitudes towards food. Did you grow up in a house where you said you must finish your plate of food? You know, there's starving children somewhere. I don't think that's said anymore. But you have to finish your plate. When somebody is forced to finish their plate, you know, it disconnects your relationship with your hunger and satiety signals. So you learn to eat until you're done, regardless of whether or not you're hungry or full. Food insecurity. If money is tight and you don't know if there's going to be food on the table next week, your relationship with food is not going to be healthy. You're going to eat what's in front of you when you can because you don't know if it's going to be there next week. Sadly, childhood trauma. When I see people with eating disordered behavior, restrictive eating, binging and purging, so often there's a history of childhood trauma, which of course is devastating. Maladaptive hunger and satiety signals in type 2. So what this means is, our guts and our brains make hormones and neurotransmitters that help us feel hungry and help us feel full. And it turns out people, not only people with type 2 diabetes, but people who are predisposed to type 2 diabetes, those hunger and satiety signals are, for lack of a better way of saying it, messed up. People feel hungrier. They feel hungrier for longer. They feel more hungry. It takes them more to feel full. And then once they feel full, they'll feel hungry again sooner than somebody who doesn't have these maladaptive levels in their system. I don't think I need to remind us all that hunger is one of the basic human drives, along with sleep and procreating. And so if you have food in front of you and you're hungry, it is hard to turn that down. And that is not a judgment call on somebody. That is just reality. It is hard to turn down food when you're hungry. And if you feel hungry more often, that's tough. Food culture, of course, we have a very unhealthy food culture. And that, again, has to do with portion sizes and nutrient-poor foods and calorie-dense foods and our lack of activity and all of the above. Limited resources. So for many people, they don't have 20 hours a week to think about this. They have a job, they have family to take care of, they have financial constraints, they need to have hours to sleep and take care of everything else in the household. So we don't always have the bandwidth that we wish we did, ideally, to take care of ourselves. Indifference to or dislike of exercise. I put this up here. I don't know much about this data, but just anecdotally, working with patients for almost 20 years now, some patients like to exercise and some don't. When you like to exercise and you get that endorphin rush, that's rewarding. I certainly have patients who exercise despite the fact that they don't like it. They do it because they know it's good for them. But it's easier to exercise when it makes you feel good. And then inadequate or poor sleep. When you're not sleeping well, whether or not it's from sleep apnea or insomnia, anxiety, all those things are going to raise cortisol, raise stress hormones, and make your whole metabolic system less healthy. So historically, I've thought of these kind of buckets. Factors we can't control, that's our genetics, our age. Factors we can control, food, exercise, and sleep. And I put the bucket of what we can control, it's grade. So clearly, we are all human beings with free will. We can always choose to make healthier decisions moving forward than we have in the past. I just want to highlight the fact of why this is difficult. And these are real challenges. And we see this with patients. These are the words patients come back to me with. I failed again. I was worried you'd yell at me. I just, quote, need to do better. And unfortunately, diabetes is one of the few conditions where we feel like we get assigned a grade, right? So the A1C is sort of like a grade of how you did in the last 3 months. Your fasting blood sugar is a grade of what food choices you made yesterday. And that all gets tied in and makes it that much more complicated. If you think about it, if you had many other diagnoses, if you have somebody with cancer and they come back to the office and their tumor marker is up, they would never say, I was worried you'd yell at me. That'd be tragic and wouldn't make any sense. But this is what we get to with diabetes, unfortunately. And yet, despite all of this bad news, this dismal data, truly, we have a lot of trials showing that with well thought out plans, with the right support, diabetes remission and reversal is possible. It's clearly possible. I see it in my practice. I know Dr. Hassell sees it in his practice as well. So I think if I had to summarize my slides with just one statement, it would be that type 2 diabetes reversal certainly is possible, and it just may not be possible for every single patient at every single time point in their life. I think when you say something like type 2 diabetes reversal is possible, that can sometimes come off as a controversial statement. I think only because we as humans really like to have absolutes. We like things to be black and white, and so if you say diabetes reversal is possible, you're going to have somebody come back at you and say, well, no, XYZ, this is why it's not possible, or it didn't work for me, or it didn't work for my patient. I think if we just appreciate the nuance of the situation, that it's a complicated situation, and complicated situations are never black and white. I would say the only absolute is if somebody tries to inject insulin into your palm, the way this picture is showing, you should run. So our goals, again, luckily, I think our goals line up well with our patients' goals. We want to be healthy and happy. Patients want to be healthy and happy. When we're talking about diabetes, we have to keep the A1C as a paramount goal to keep in mind in order to avoid complications. But the other aspects of health that we can and should think about are independence. What do we want our health to look like 5 to 10 years from now? Do we want to be mobile? Do we want to still be able to be active with hobbies and family and enjoy those activities and not just be somebody sitting on the sidelines because you don't feel well enough to take part? For a lot of patients with diabetes, avoidance of low sugars becomes a big health goal because, of course, a lot of the medications we use can cause low blood sugars. And that's a big sticking point for a lot of patients, that fear. From the happiness standpoint, it might seem strange to think about happiness in the context of diabetes, but when I think about this, I think about the flip side. I know a lot of things that make patients unhappy, and that's when they're feeling overly burdened by their disease management. So whether or not that's having to check their sugars constantly, having to think about these things constantly, that's burdensome, that's exhausting. It's emotionally exhausting. So if we can get patients to a place where they are healthy and it's just become the new normal for them, and they are no longer having to think about their disease multiple hours a day, that's happiness. The other aspect of happiness, I think, is empowerment. And this comes from patients understanding why we're making the recommendations we're giving them and for buy-in from the patient. If patients feel like they have some say in the matter and they're making the decision themselves to become healthy as opposed to just following some authoritarian rule, that is going to lead to empowerment, and that helps with happiness generally as well. So how do we navigate this divide, this big division between what we need to do and how do we get there? Well, again, we have to always ask the question, what's motivating this patient? And here's where I think about thinking about health over numbers is helpful. So if you have a food choice to make in front of you, if you think about the fact, how am I going to feel physically in my gut after I eat this? How is this helping me or not helping me reach my goals? That's going to be much more motivating than thinking, I shouldn't eat this because then my A1C is going to be high and then I have to go see the doctor and blah, blah, blah. We need to think about where we're at and where we need to be. And so for some patients, making multiple small short-term goals is helpful. So we'll decide on 2 or 3, maybe little bites, little things that we can change each visit that we're going to work on and slowly chip away at what we're trying to work at. For other patients, they really need large sweeping life changes. So we kind of think of those big 180 turnarounds that some patients make. And I find that often patients can tell you what works best for them. We want to see a little bit of active engagement at each visit. So we're all pressed on time. It can be easy to get into a state where you're just kind of checking things off the box. So each visit, okay, what's the A1C? When's your next eye doctor visit? Are you having low blood sugars? But really no real engagement. So what we need to try to do, both the providers and the patient, is to actively be present at each visit and come away. It doesn't have to be a big light bulb aha moment, but come away with one little nugget where we identified a challenge area and then we're going to work on it. We need to make sure we're not setting patients up for failure. There's going to be some patients for whom this is just not the time or the place, or medically it's not the right choice for them. Dr. Hassell and I are going to be speaking quite a bit about that later this morning. In terms of solutions, time is a tough one. Of course, we're all getting pushed to see more patients in a shorter amount of time. I think one potential solution to this is if you decide you want to make this a focus of your practice, it does take time. And so possibly more frequent visits, I think, is the answer. And that takes buy-in from the patient as well. Luckily with telehealth, that's a bit easier. Continuity, I think it's much easier to achieve our goals if we're seeing the same people back and forth, the same provider year after year, so that we really get to know each other. Curiosity, we have to still stay curious. Again, and that gets back to that level of engagement, a little bit of engagement at each visit. And then personal interaction, this is just my plug for something I've been thinking about the last couple of years. Artificial intelligence is taking over a bit of our medical practice, and it's going to be even more so. I think that might have some role for doing the initial workup for a rash or a broken bone, and I'm probably really insulting my dermatology and orthopedic colleagues when I say that. But I feel like these conversations are a bit more nuanced, and I'm going to fight to keep having human interactions with patients. Okay, we'll quickly finish then with coming back to these patients. So Robert, new diagnosis of type 2 diabetes. He is surprised but not surprised, but he's feeling very motivated. He wants to get on top of this. He has a couple of what I would call low-hanging fruits. So he now has access to a gym. He's been drinking sweetened coffee drinks that he says, sure, I can give those up, and ice cream at night. So we get rid of those things. He's easily going to get back into the pre-diabetes or non-diabetes range. And this is a time point where he's going to be motivated because the diagnosis was just made. Ruby has had diabetes for 10 years and her A1C is 10 on 3 meds. She's feeling maxed out on what she can do, and when we talk to her more closely, in fact, she is doing a pretty good job with her eating and activity. And so she is probably somebody who's going to need insulin. Again, she has an autoimmune piece as well. We're going to talk more about that later today. Fiona has had diabetes for 6 years. We've been talking about maybe should we add a second medicine or not the last few visits. We're kind of in a point of clinical inertia. Nothing's really happening. So when we dive into a deeper conversation with her, we learn she has an aunt on dialysis with an amputation. She's terrified of ending up like that. She values her time walking, hiking, and traveling with friends. She really wants that that's a health goal for her to keep that up. In the interest of time, I'm going to gloss over the rest of this, but there's a lot of things that we can take a deep dive on in terms of how patients are doing. How can we help them set them up for success better so that the healthier choices are easier to make? And we have a couple of experts who know a lot more about this than I do in the next few hours to go over these changes with us. And so with these changes, she is able to get her A1C down to 6.6. I don't have a summary slide because I knew this was going to be really fast. This 20 minutes, I probably went long, was going to go by very fast. But I just wanted to leave you all with this, that diabetes reversal remission is absolutely possible. It's not easy. If it were, we'd just all be doing it. But it's absolutely possible for a large number of patients. And it just takes the time and the curiosity to figure out who those patients are and how we can best get there. Thanks.
Thank you, Von Wolf. I am so interested in hearing more about the impact of gestational diabetes on childhood development. And later we'll hear about a lady who was told by her healthcare providers, you've had gestational diabetes before and you will again. And with every child you have, I'm sorry, but the news is you'll have gestational diabetes. And that lady said, I know there's a better way. And so with her next pregnancy, she did not. And that one lady became 2, became 3, became 100. So we'll hear more about that soon. I'm so glad Dr. Wolf talked about food insecurity, lack of resources. We've set up a cute little table here of jars from my garage shelf with some Winco bulk prices on them. And that's where we point people when they say, I can't afford healthy food. Well, let's look at beans and grains. They last quite a while. They're pretty cheap, and let's teach you how to make them. All right. And I've already introduced Dr. Hassell. Dr. Hassell, come on down.
Thank you. And Fawn says thank you too. So we're going to just touch on what are we really saying when we're talking about reversing type 2 diabetes. And I would argue that we're really saying we're trying to reverse insulin resistance. And that's a useful thing, I think, to teach our patients about. And that almost always requires weight loss, but not always. There's many people who have insulin resistance who are pretty thin. But the good thing is they seem to respond to the same things we're going to be talking about today anyway. And of course, some of them end up being what Fawn was referring to at the end. They're actually people who require insulin because their pancreas doesn't produce insulin. So that's always worth thinking about. The second thing we need to be thinking about when we're talking about reversing diabetes is we're trying to reverse or prevent long-term complications. That's what Dr. Blair was talking about. The horrifying, amputations, kidney failure, dialysis, going blind, and so on. Strokes. The strokes is really the thing I really like to talk to our patients about because it's often the thing that they're most familiar with. They often don't know somebody on dialysis, but they usually know somebody who's had a stroke and the devastating consequences. And therefore, then blood sugar, instead of being the dominant metric, becomes just a measure of progress. And then we can use it as a critical weapon, like Fawn was referring to, which makes patients feel bad, or as a marker of, hey, this is how we're going to measure this, just like a tumor marker. And here, okay, that didn't work. What do we do now? And so painting it in a positive light. And in 20 minutes, I'm not going to be able to cover everything that I would like to talk about in, like if you had till about 9 o'clock tonight. So on our website, there's a whole bunch of free information at greatmed.org. And then the book that my sister and I wrote covers all of this material too. When we're talking about insulin resistance, really quick, we're talking about typically it's sort of often the first thing that people notice is their blood glucose is a little high routinely. Then we can sort of start adding in other factors like you got a tummy, you got high blood pressure, triglycerides, low HDL cholesterol. This complex, which we could call the metabolic syndrome, often you could also call it prediabetes in most patients, whatever you're going to call it, that should be the red flag that we respond to. We shouldn't wait for people to get diabetes. So people in their 30s and 40s should be targeted to say, you know what, this predicts diabetes in the next 10 or 20 years for you. Do something now, don't wait. And so the preventing diabetes is arguably a more important thing to think about as a culture than reversing it. But for the person with diabetes, of course, that's a little late. And then you add up all these factors long enough, and with the passage of time, and often type 2 diabetes appears. And I should mention, I forgot to mention this on the last slide, the complications that we see with type 2 diabetes, we also see with prediabetes. And so what I often say to my patients is, I'm not sure that prediabetes really is a pre-anything. Maybe we should just call prediabetes diabetes. Because although the complication rate is lower, the same complications occur in a prediabetic as occur in a diabetic, just at no lower frequency rate. And so what leads to all this? Sedentary lifestyle has been referred to, excess waistline has been referred to, diets high in refined carbohydrates and processed foods, maybe diets high in naturally occurring carbohydrates, but I'm beginning, the older I get, the more I'm thinking that those are actually a factor, but I could be wrong. Diets low in fiber, certain micronutrients are frequently associated with more diabetes, lack of sleep apnea, that both Fawn and Dr. Blair both referred to. It's interesting, small amounts of alcohol are actually protective, large amounts are not, partly because those people never show up for studies. Certain medications, steroids, a bunch of other medications that we use can lead to diabetes. Aging is, don't let that happen to you. And of course, anybody who chooses their parents poorly, as Dr. Wolf referred to, that's on you. So what do? You refer again to what you've heard from Dr. Blair and Dr. Wolf both about thinking about all of this is should be motivating, of saying, here's what happens when you have diabetes. Here's what happens if you can reverse that process. So I'm hoping that this kind of thing becomes motivating for people. But some of the things that often are thought about, Dr. Blair and Dr. Wolf both have talked about vision loss, for example, infections, kidney and liver failure. And then you get things like, there's a lot more depression. there's a lot more osteoarthritis. So your risk of a joint replacement if you have type 2 diabetes compared to this person of the same weight without diabetes is roughly doubled. And so on. You can just see this cascading effect of having diabetes or insulin resistance. And when this is still thinking about the pre-diabetic category, not necessarily diabetic, although this would refer to both. The more of those risk factors you have for the metabolic syndrome, what we talked about earlier, which is high blood sugar, waistline that's excessive, high blood pressure, high triglycerides, and low HDL cholesterol, the more of those factors you add up, the dramatic increase you get in heart attack and stroke risk. So, for example, somebody who with all those risk factors, which is an awful lot of our 40 and 50-year-olds in my practice, I'm afraid, they have high blood pressure, but they're being treated, so they think they're okay. They have high blood sugar, but they're being treated, but they think they're okay, and they're not. Their risk of stroke and heart attack is still 8 to 10 times normal. And that shouldn't be overlooked, in my view. I like this one Dr. Wolf referred to some of the hormonal dysregulation that occurs in diabetes. And one of the things we like to point out is that tummy there on this guy, it's an estrogen factory. He's carrying around his own estrogen source. That's not a great idea for males. You can just let your mind go in terms of apathy, muscle mass, and so on, where that's going to lead. It's not good. And one of the things as a culture, we often wait for the type 2 diabetes diagnosis to occur. And we shouldn't. And the reason we shouldn't is because the risks of heart attack, heart disease, and stroke doubles or triples 15 years before the formal diagnosis of diabetes. And this is from the Nurses' Health Study, so something like 120,000 nurses followed for something like 30 years and followed carefully. So these weren't misdiagnoses. But the risks start well before people have type 2 diabetes. And so what do we do? This was supposed to be a weight loss talk, and you'll notice I still haven't gotten to weight loss. So we talk about what to eat and how to eat it and still lose waist. And it's worth remembering that just the degree to which all of this has an impact. So this is also Nurses' Health Study data. People who followed a decent diet, nothing special, just a normal grandmother diet, who weren't chubby, who got 30 minutes or more of moderate to vigorous physical activity every day, drank small amounts of alcohol but not too much, and didn't smoke, lived for about 12 or 14 years longer, and had about 90% less type 2 diabetes. 90% less, with a very, very simple set of choices that all of us could make. And then Dr. Wolf also referred to the literature for type 2 diabetes reversal. So I won't dwell on that, except to point out one piece of data. In the direct study, one of the studies she pointed out, at 2 years, 70% of the people who initially had diabetes, who had been treated, still did not have diabetes if they lost a substantial amount of weight. 70%. So we're seeing, arguably, and in the Nurses' Health Study, 90% reduction in type 2 diabetes risk. In this study, 70% reversal at 2 years. So we have very, very substantial data showing dramatic reduction in risk. So let's apply this to a real human. So this lady who came to me, she'd just been told she had diabetes. She's 44 years old, 3 kids, had gestational diabetes, which Shelley's going to be talking about in a minute. And her initial HbA1c is 10.7%. So for those of you not familiar with this is a pretty poorly controlled diabetic, and this is right out of the chute. She obviously had diabetes for some time because she already had liver injury, and she had evidence of kidney injury. And she's only 44 years old. She's got a lot of time to suffer from the consequence of diabetes. Oops, sorry. So we talked to her and apparently connected with her because she was able to lose a certain amount of weight in 4 months and reverse her diabetes. And then she continued losing weight and has continued. We're now at 4 years with her, and she still does not have diabetes back. Her liver injury reversed, her kidney injury reversed, and her future health, I think we can predict, is dramatically better. And if you just look at the cost, forget the human cost, the misery that she has saved herself, but also the cost to society. I have patients who are using $10,000 to $20,000 worth of diabetes medicines a year. Many. And just think of that cost. So, but it doesn't have to be young people. So this lady came to us at 77 years old. Now she was really motivated because she just, I met her, I was admitting from the ER, she had a stroke. So I admitted her to the hospital and she had diabetes and high blood pressure and so on. And I said, hey, you might get a second stroke. And which she appreciated that comment, I'm sure. For the first couple of days, she couldn't actually speak because of the stroke. And so, I could just talk. So anyway, she's 77 years old. She's from Nicaragua. She actually spoke very little English anyway. So I really had to open a course. And so I talked to her about the basics of diet and exercise and said, you could really do a lot better for yourself. And indeed she did. And at 99 years old, she died without diabetes. Still living at home. So what do? We think about planning. If I say to a patient, what are you going to have for dinner tonight? And they can't tell me, we know we're in trouble. If you're not planning, you're not going to be successful. We want low calorie density and high nutrient density. So that means you minimize foods made outside the home. You minimize sweets, especially liquid calories. And if you're somebody who has a few glasses of milk a day, even that's, in our practice, seems to be an issue. Include with every meal and snack vegetables and whole fruit and eat them before you eat anything else. Imagine that you ate an apple before anything else every time you were going to eat, for breakfast, for lunch, for dinner, for snacks. But before you had anything, you had an apple. You'd eat a lot less. Portion control is an issue, but if you do this, you don't need as much. If you're still hungry, you have protein and good fat. And all of this is discussed in our book. Be active. And in diabetes research, being active more than once a day is a really good idea. And Diane is going to be talking about that, so I won't go on. Be accountable. It could be a spouse, it could be a kid, it could be a parent, it could be your physician. But have a reason to be doing this for yourself. And if you're accountable to somebody else, we all do better when we're accountable. We use a Mediterranean diet model. I won't go into this in any length, but the basic issue is for both general population and for the diabetic population. The evidence for the Mediterranean diet model, which is easy for most people to follow, has by far the best data, partly because people actually stay on one of the things that people comment on in the studies is if you're on the Mediterranean diet model, you're more likely to stay on it. I won't go into the studies in the interest of time. I will comment it involves lots of fruits and vegetables, beans and legumes, minimally processed whole grains. Olive oil is the main fat. Good fat with each meal and snack. That really makes food more satisfying. Low-fat diets are not Mediterranean diets as a general rule. Most animal proteins are part of it. Cultured dairy, we'll talk about the microbiome in just a second. It usually includes moderate alcohol. I'm just going to do a shout out for extra virgin olive oil because it is the only kitchen fat for which we have good evidence of improved health outcomes. And so I think that's a really important thing to think about. The microbiome, you want probiotic foods in your diet. So if you're not having fresh sauerkraut, every patient I say, hey, what probiotic foods do you have? And they say, what are they? And it's fresh sauerkraut, kimchi, yogurt, and kefir. I would argue apple cider vinegar should probably be part of the probiotic food category. We could talk about why, but regardless of where you put that, it does seem to be associated with better blood sugars. Avoiding commercially processed foods. So commercially processed foods, that's foods processed outside the body, outside the home, sorry. Foods processed outside the home. Can you delete that? Are associated with quite a bit higher type 2 diabetes risk on a dose-related basis, as well as higher risk of dying, higher risk of cancer, higher risk of stroke, higher risk of depression and anxiety. You have to make your own food. And making your own food also saves you money. It's better for your family. But it means you don't want to do something else. And so that means you have to read labels really carefully or buy foods without a label, right? So you don't have an ingredients label on barley or broccoli or steak. If you don't have an ingredients label on something, it's probably what you should be buying. Exercise. This is a paper that Shelley and I wrote with Heather Martin about the idea of being short of breath and sweaty every day. and how much, how good that is for you. This is one of my favorite patients. At 88 years old, what he decided to do? He decided to go a 15K fun run at 88. I bet you a whole lot of you don't enjoy a fun run at whatever age you are, let alone 88. And it's not too young to start. This is my son at about, I imagine he was about 6 in this age, and he's a little bit bigger now. Hey, Tor, you're outside eating to make sure he keeps growing. He's a little bit, but you know, get in the habit of exercising with your kids, with your parents. You can't start too young. And so in summary, if you're going to lose waste, you have to eat foods made at home, I would argue. You want to minimize sweets and foods made with flour. Breads, pastries, crackers. Even though they're non-GMO and whole grain and organic. It doesn't, labels with earth tones. You still shouldn't eat them. Think about portions. Have you had enough? Is it time to put the fork down and eat a piece of fruit or vegetables instead? Daily exercise we talked about. Start every meal and snack with a whole fruit or vegetable. I'm pretty sure that this would cure obesity. I'm pretty sure. I don't think I've ever seen it not work. And identify and respond to risk factors for insulin resistance as soon as you can. And just a shout out for greatmed.org, which is started by several people who said, hey, this is worth doing. And they've put in the funds to make this all possible. And our job is to change the culture of thinking about health so that, because health is far too important to leave to physicians. Health is something that you have to think about. And you have to help other people in your culture to think about. And don't let that slide. It's more important than most things in life. As Dr. Blair said, getting to heaven is the most important, and being healthy while you're here is right up there. So I'm going to hand over to Diane Schiffer. Thank you.
Thank you, Miles. As Miles was saying, many people with preventable diseases want to make lifestyle changes to improve or reverse their condition, but they don't know how. And that's why we're here today. And so greatmed.org, feel free to check there for our resources, our type 2 diabetes reversal guide, offering patients a better way to get better. So take down your questions for Dr. Hassell. He'll stay as long as you want to stay at the end and answer questions. And again, shoot them to greatmed.org, info@greatmed.org if you have questions. And man, anyone in the room heard about our 6 apple challenge? Raise your hand if you've heard about it, if you've tried it. There's a couple, there's another. Really, we want to emphasize that fresh fruits and vegetables might be an ally, and you don't have to feel starving. So I want to introduce a good friend, Diane Schiffer. She combines expertise and passion to empower others in their health and wellness journeys. She earned her degree in biology from Willamette University before completing her physical therapy education at University of Puget Sound. With over 3 decades of dedication to orthopedic care, Diane achieved her Orthopedic Clinical Specialist, or OCS, certification through the American Physical Therapy Association. She also is one of the few that has a certified manual physical therapy degree through the North American Institute of Manual Therapy, further enhancing her hands-on approach to patient care. And she really has a practice like no other. I've never seen anything like Connect and Beyond physical therapy. So after your physical therapy episode is completed, then what? Well, she has a whole menu of specialists right there in her clinic with exercise equipment who can help you safely continue on with your program. Tai Chi, Pilates, balance stuff, it's a pretty fantastic thing. But please join me in welcoming Diane Schiffer.
Help me make sure I'm all set up here, will you? That'd be great. That's going to sit there. Okay, and let's get that set on. Okay. Good morning. I am Diane Schiffer. That picture is several decades old, which I love thinking about. I feel really humbled and grateful to be part of this group today. You're listening to some amazing experts that have detailed, really excellent experience and expertise in metabolic disease. I am not a type 2 expert by any stretch of the imagination. So if there are technical questions that need to be asked about this disease, I refer you to Dr. Wolf and Dr. Blair and to Miles and to Shelley. But what I am a content expert in and a lifetime expert in is movement and helping people move well and using their bodies as a lifestyle medicine tool. 40 years, 47 years to be exact, of being a physical therapist, and I still love what I get to do every single day. I'm not used to large group speaking. I'm used to seeing one face and talking one-to-one and working in single partnership with an individual. So if I kind of glump you all together into one face, I'll probably feel a whole lot more comfortable. As a PT, I have spent my career working with individuals to identify specific issues, looking at biomechanical issues, range of motion limitations, strength limitations, sitting down, listening to the person's story. That's probably the most wonderful part of the work that I get to do, is to listen, to have the time. Dr. Wolf mentioned how difficult it is anymore with time between each visit, or time with individuals is limited. We have the luxury in our practice of spending an hour with our patients, listening, evaluating range of motion strength, setting specific goals for individuals, and then deciding and building a plan that helps them reach their goals. This is a privilege, and that is never lost on me, that I have the opportunity to partner with people to help them discover what their goals are, and then how can we break it into bite-sized pieces so that people can achieve that. A couple of people this morning have talked about the complexity of the problem of type 2 diabetes, or I would say any issue that is facing a patient in their moment of challenge. And that's the best part of a collaborative team, is that I know that Miles is handling one thing, Dr. Wolf with her endocrinology expertise and excellent and medication base is managing one thing, someone else is managing eating and food source, and we get to play the role of managing movement and how we use movement as medicine. So today I've been asked to talk about physical activity and, sorry, I'm dry mouth, physical activity and type 2 diabetes. And I'm going to talk about physical activity and muscle mass for diabetes, reversal or management. And we'll talk about muscle mass and how we build muscle mass and why that's important. But I'd also really like to talk about the psychology of movement and disease management, and talk about how in the world do we help create a plan that helps people not be overwhelmed in the moment, at the time of that diagnosis that feels horrifying and terrifying, and all the things that Dr. Blair and Miles talked about, all the big scary things. How do we come alongside people in the moment and help them work on facing that challenge? I never want to fight in the ring, I always win in preparation. Now, I'm not a boxer, but I love what Muhammad Ali said about that. It's not when we're in the fight that we feel most empowered, it's before we get into the fight. So I love what Miles said, is maybe prediabetes should be called diabetes, so that people really do start to take responsibility and accountability for that. But we don't want to blame the patient, and we don't want to have people feel like they don't have an opportunity to find a direction to move forward. Wouldn't it be great if we didn't have to wait for the crisis, but that we had the opportunity to prepare? Let's break that down to a micro perspective, though, and think about how do we help each individual prepare for the day. And that's part of what I want to talk about movement today. So physical activity. In 2022, the American College of Sports Medicine put out a consensus statement, and they suggested broadening the definition of physical activity, and to broaden it to include all types of movement, emphasizing the importance of reducing sedentary behavior and incorporating regular activity throughout the day. In other words, movement as medicine. There's a difference between physical activity and structured exercise, and sometimes they get mixed up a little bit, and we think Dr. Wolf had mentioned that lots of people don't like to exercise, and I think that's true, because exercise holds out sort of a punitive component, or I'll never be able to do it, or I'm gonna fail at it, or I'm gonna get hurt, I'm kind of afraid to start something. So it's important to recognize that physical activity are things like taking a brisk walk, choosing to walk to work versus riding in a car, taking the stairs instead of an elevator. Functional tasks like gardening, yard work, cleaning your house, even though that doesn't sound very fun. But we all do it. Activities of daily living, hiking, dancing, turn up the music super loud and don't care that anybody watches you. Playing catch or frisbee, throwing a ball against a wall, Pilates in a more organized sense, but even those are more lifestyle movements. They're not structured exercise so much of counting repetitions, looking at the load that you're pushing. Team sports are also a really great fun way to continue to look at physical activity. Planned workouts are a little bit different. Exercise, as we think of it in the classic form of therapeutic movement. There we have specific goals, specific work measures, and specific targets that we're working at. Regardless, all physical activity, all movement as medicine, both either physical activity or structured exercise, influences metabolism. It improves our insulin sensitivity, enhances glucose control. It helps us lose body fat. And through fat loss, we decrease inflammation. Inflammation is a huge issue for people with either prediabetes or diabetes in that it infects the way they can move effectively and efficiently through the world. Who wants to exercise when it hurts? We can also look at it as boosting our metabolic rate, which helps us to have the right foundation to build muscle, that we're going to talk about just in a second here. And then the other thing that we know happens with physical movement, whether it's physical activity or structured exercise, is it helps regulate hormone balance. Miles just referred to that a few minutes ago, which helps us with building muscle, but also with that chronic inflammatory response. So I just want to take a quick second here then and talk about two other factors that I'm going to lump into physical activity because I think they're important to mention. And they're both things that we can affect in our lifestyle approach to managing chronic disease or chronic pain. And the first would be stress management. So we know that stress affects us negatively in all kinds of components, but one of the things that we incorporate into our practice quite a lot is teaching self-regulation of that fight, flight, or freeze response, which is the hyperactivation of your sympathetic nervous system. Not great things happen to the body when we live in fight, flight, or freeze. And so taking the time to learn something about self-regulation, whether it's mindfulness, meditation, just teaching a counted breathing practice, a six-sided breath, whatever your maybe exposure to it has been. For years, I incorporated biofeedback into my practice, which is the process of taking physical measuring devices to look at those many of the factors of the sympathetic nervous system, heart rate, blood pressure, muscle activity, making the invisible visible, external monitoring devices to help people see what is my body doing when I can feel my heart rate beating faster, or I'm super mad at my spouse, or I didn't get whatever I thought I wanted to get, and that internal response. So I'm incorporating a little stress management into a physical activity as well because it will have such a profound effect on your metabolic health. And then the other is restorative sleep, and several people have mentioned sleep this morning. Super, super important. Sleep helps us prevent some of those inflammatory processes, and the more inflamed we are, the less we like to move. It becomes kind of a vicious cycle. Also, the more I move, the better I sleep. There is a continuous circle around all of those lifestyle medicine pillars, and if we think about each of them and think about them in concert with each other, whether it's activities of daily living or a structured exercise program or stress management or improved sleep, all of those things combined with a healthy diet and weight or waste management, as Miles says, helps us increase our chances of managing that metabolic disorder. Okay. Now you know my biases about healthcare. Muscle, it's a beautiful thing. It's not only beautiful to look at. We saw the two examples from Dr. Blair, which were fabulous, of two types of steak, which I thought was terrific. Muscle is the main event. It's really what gets us through life. It is, on a metabolic standpoint, it is the increased muscle mass enhances so many things about our metabolic health, including glucose uptake, glycogen storage and utilization, and reducing blood glucose during exercise. But biomechanically, it's the bomb. It's what powers us up. It's what gets us out of our chair. It's what propels us through the world. It's what supports our painful muscles and joints. It provides the catalyst for all functional movement. If you're under-muscled, you don't move well. And that life is just harder to get through. It also allows us to do the type of functional activities that we enjoy, that give us joy. Happiness, Dr. Wolf mentioned, is a key factor about having a successful model for living. And then one of the last things that we'll talk about is it prevents injury. It makes us capable of having improved balance, improved strength for functional lifting, lifting a bag of groceries in and out of the car, a suitcase overhead into an airplane if travel is one of our desired ideas. But what type of exercise? Because that's the big conundrum. Is it physical activity, or is it a specific type of muscle, a specific type of strengthening exercise? So this is what the literature says about the types of exercise for type 2 diabetes. Again, this American College of Sports Medicine consensus paper recommended that individuals with type 2 diabetes perform resistance training 2 to 3 times per week. So we're just going to run through them, and then I'm going to double back. So there's strength training, aerobic exercise, which has been recommended to have a daily dose of, a high intensity interval exercise, and then daily movement and activity. That kind of I would put into that physical activity bucket that we talked about a few minutes ago. So when we double back to strength training, the 2 to 3 times per week dosage that is recommended. To do resistance training, we need to push a load that is heavier than what we think we can possibly work. If we work through without a load, we are not going to increase muscle mass or muscle strength. The load could be as beginning as body weight, and for many deconditioned individuals or people who don't like to exercise or who haven't exercised consistently, it can be doing a repeat sit to stand without using hand assist, and that's a resistance training because you're moving your body mass through space with a load. Other loads that we typically think of that we might be using are bands, weights. Let's see, we've got body weight things like push-ups and squats and lunges and planks. Now we're not talking about physical activity. Now we're talking about measured exercise, and this is a disconnect for some people. This is drudgery, and it's very challenging to get people to buy in often. So. The key is, I think, in the research in strength or resistance training, we agree that you have to push a load. The pivot point is, what is a load? And I think having an expert, Miles talked about an accountability partner, I think my bias as a clinician and as a physical therapist is this diagnosis allows anyone a course of physical therapy. I could guarantee you there are 10 or 15 comorbidities that could be called out as an ICD-10 that would require a case or course of physical therapy. There's hip pain, knee pain, all the pains, all the itises. And I think being able to engage with a clinician that can do a screening exam that doesn't take a ton of time, where you quickly call out what joints are in trouble, what muscle groups aren't performing well, and then work with that individual to help you do a thorough evaluation, taking into perspective the other comorbidities that you have. If you have an ankle that doesn't dorsiflex more than 10 degrees, you're not going to do great at squats. And so going to an exercise class where squats are recommended, while they're a fantastic exercise, you're going to fail at that activity. And then once again, I can't do it, I'm afraid of doing it, I'm going to get injured, and you might. So I think for me, it's not just about having an accountability as a partner, a spouse, or a good friend. It's considering seeing a professional person that can help you figure out what is your starting place, start there, and begin the process. Generally, starting strength looks something like 7 to 15 repetitions of an activity, 1 to 3 sets. That's what the literature would support. But if you're starting from a very deconditioned, it might be 5 reps of one activity. Okay, so strength training. This is where we build most muscle mass. This is where the evidence is pretty strong that if you're trying to build increased muscle to help with the metabolic benefits of muscle, it needs to be acquired through strength training, resistance training. Okay, aerobic exercise, daily. Muscle mass isn't the only thing that we think about in functional movement. We also need endurance and cardiovascular health. Those same ACSM guidelines recommend that an individual with type 2 diabetes engages in 150 minutes of aerobic exercise weekly. So that could look like 30 minutes 5 times a week. It could look like any metric that you want it to look like. We generally think of a dosage 20 minutes plus, but again, where are you starting? If it's 5 minutes 4 times a day to get your 20 minutes in, then good for you. You did it, and that's successful, and you didn't get injured. There's a lot of conversation in the literature about aerobic exercise right now, but generally I would say that a zone 2 target, and that's again something that somebody with medical background can help you, or for coach or personal trainers have deep expertise in this area as well. But figuring out what does aerobic exercise look like? What does zone 2 mean for you? It generally means that you could talk while you're exercising, you would just prefer not to. And I think Miles said short of breath and sweaty, and that's probably true as well. But that could look like brisk walking, it could look like cycling, it could look like swimming or hydrofit, it could look like dancing in the kitchen. It doesn't have to be something that looks like drudgery. It just needs to be continuous and challenging. So we have strength training for muscle mass, aerobic exercise for cardiovascular, and endurance training. And then the third one, high intensity interval exercise, might be new to some people. This is short duration, high intensity activity. This is particularly helpful in helping us gather our glucose uptake and also make us a more effective or efficient in insulin sensitivity. So there's a lot of variability in the literature about high intensity interval training, and if you've never done it, it will feel daunting because it's not very comfortable. It's to do something as hard as you can for a short duration, followed by a short duration rest, repeated multiple times. It could look as simple as an all-out sprint or an all-out jumping jack episode or an all-out running in place for 20 seconds, followed by a period of 20-second rest, repeated for 4 minutes. That's an intense Tabata workout. Not very many people are going to start right there. But you could very easily start by 5 sit-to-stands without using your hands, and that might be intense for you, and a max out burst of energy. It might look like when you're on your brisk walk, you jog between one telephone pole and the next, and then continue your walking. It's this intermittent, high-intensity activity that is as hard as you can go. To start, it probably could be 10 or 20 seconds, repeated, followed by a longer period of recovery. Not rest necessarily, not stopping moving, but I do them in the pool. I do a burst of a 50-yard sprint, and then I swim a 50-yard very slow, very slow. It's a recovery period, and then you sprint again. So this might be new for people. I would encourage, again, the coaching, the personal trainer, someone that's coming alongside you to help you understand what it might look like for you. Strength training, aerobic exercise, high intensity interval, and then we're back to physical activity and daily movement. It really is about stopping the sit. If you set up your daily activity that you had to be out of your chair every hour on the hour, do things that can help you make that happen. Set your phone across the room. Leave your phone in the kitchen while you go off to sit at your desk and do some work. And every 30 minutes you get up to go check that phone, or leave it in the car, or better yet, turn it off. But make yourself have to go somewhere and move hourly as often as possible. Devices can be really helpful. Okay, I'm getting the high sign back there, and I haven't even gotten out of how to build muscle, but this is sort of the nugget. This is this thing about muscle. This is what we want to think about. The insulin sensitivity is really helped by the high intensity interval training. The best way to build muscle mass is resistance training. You'll get cardiovascular benefit from both the aerobic and the high intensity. And so we'll leave it at that. The next couple slides to me are more about the psychology of movement, and this is as important as how to move, because you could have all the information and know what to do and never do it, and it won't help you. So I want to just take a couple of minutes, and you can slide me or shoot me again, and I'll wrap up. But why don't we do it? If we know it's helpful, we have all the statistics. Why don't we? Why can't we overcome the inertia? I think the study from the American College of Sports Medicine, this consensus statement, so great, but and a couple of books I've read on changing habits and how to incorporate change into our routines. The thing that stands out the most for me in this is a personalized plan, not a plan that you get because 4 other friends told you how to do it. Today's culture, there is so much overload of information. Just open your phone to any social media, the 5 best things to prevent hip pain, the 3 things that are going to fix your neck, the 11 things that are going to do something else. And so that's all great. I take information off of that all the time. Oh, I'm going to sneak that into my Melt and Move class on Thursday mornings. But if you have specific comorbidities or limitations, they may not be right for you. So personalizing your plan, knowing where to start, what to do. The afraid of getting hurt is a real thing. Fear is a thing, and it's important to give it its space. This is a place where I love to think about incorporating our mindfulness, breathing, meditation. Do some things to downtrain that sympathetic nervous system that has you on 5-alarm fire that I'm afraid I'm going to fall over. And some people might. And that's why it's so important to have a well-prescribed plan that fits the individual capacity of your abilities. That can be coach, trainer. I'm biased towards the physical therapist, but 47 years later, I love what I do. And it's going to be too hard. If we work with someone who knows our capacity, it doesn't have to be too hard. It just needs to be consistent. So how do we get started? We've talked kind of around a lot of these things. Prepare to prepare. Muhammad Ali had it right. We win in the preparation. We win in assembling a team around us that understands all of the things we need. The medical model, the movement model, I would call it mind-body-spirit model. There's a great lifestyle medicine doctor, Dr. Chatterjee, out of England, who wrote a book called, it's called 5 in 5. And he recommends taking 5 minutes 3 times a day to address a body, mind, and he calls it heart. I would call it soul or spirit. But to do something 3 times a day for 5 minutes that help address that sort of holistic or global look at your health. Partnerships help. It can be a friend, it can be an accountability partner, it can be someone you can call when you're afraid, or I just can't get out of my chair today to make myself happen. Having that predesigned, having that commitment to each other really makes a difference. The small steps, there's Dr. Chatterjee's 5 in 5, I think is so great. Making activities that are accessible, the wearables can help. And then I think SMART goals are really helpful, and a lot of people incorporate those into coaching or health education or in other places in medicine. Make them specific so you can track, you can see right away. I liked Dr. Wolf's reference of how we feel judged maybe by the A1C or that you're measured all the time, but specificity in movement is terrific because you can say, wow, I couldn't do 3-pound curls 6 months ago, and look at what I'm doing now. So that specificity, the measurability of a goal, the achievability, make it small enough that you can feel successful. Relevant, what do you like to do? It doesn't matter if you can squat 100 pounds if that isn't going to make something better in a functional activity that is relevant to your life. Or squatting isn't possible because of other comorbidities. Needs to be relevant to your lifestyle and your specific goals. And then the final part of a SMART goal is time bound, making sure that we look at not making it, I've just got this huge amount of work I have to do forever and ever and ever. It's never going to change. Okay, so I think rewarding yourself also is a huge thing. I have a patient, I know I'm running out of time, but I want to tell you, I thought this was so clever. She went to the bank and got out a couple $100 of $1 bills. And she had something that she wanted to buy. It was a piece of clothing for her exercise, which I loved, which she thought was too expensive, but she decided she would make it a reward. So every time she did one of her prescribed exercise routines, she put a couple $1 bills in a bucket. And then all of a sudden she had this money to buy this little treat for herself. So she rewarded herself. She set sort of a goal, and in a fun and kind of sassy way, rewarded herself. I think enjoying the journey is key. Happiness, joy are really important factors. And I would come back to the same equation that I talked about in the beginning about building a team. I think building an equation full of all of the lifestyle medicine things that you and your patients already have access to. So exercising regularly, eating whole foods. We're going to hear a whole bunch of good things about that in a bit. Managing your stress. I really can't emphasize that one enough. I think it's a huge roadblock that we don't spend enough time talking about. Prioritizing sleep and maintaining a healthy weight. So I'll end where I began, and it's all about the preparation. So I hope this has been a little bit of helpful comments about you preparing for yourself as well as for your patients. Thank you.
Jeff. So Jeff,
Miles.
so Jeff and I have known each other since the early '90s, and he's had quite a health journey to touch on briefly, but he's also found some really handy solutions to some of the challenges that we all face that have really helped him. So Jeff, I first met Jeff when he was a medical assistant, and before that he had been, were you a police officer for a while?
I was a reserve. Yeah.
And he ran a grocery store for a while?
Did that for many
Yeah.
years.
And now he's runs IT in Providence. So he's a man of extraordinary talents.
But if you do work for Providence and have a problem with Citrix,
Who would ever have a problem with Citrix?
honestly,
Or Providence?
it's never Citrix.
Yeah, okay. That's probably the nut behind the wheel. Okay. So Jeff, tell us a little bit about your health journey and how it relates to diabetes. And I should mention in the background, Jeff has type 1 diabetes, so insulin dependent. His pancreas doesn't work. So a lot of what we talked about doesn't directly apply to type 1 diabetics, and yet most type 1 diabetics also have some insulin resistance, and that's where the lifestyle measures can really have a huge impact. So Jeff, tell us about you.
So when I had my initial diagnosis, it was about 23 years ago, I believe it was now. And it was interesting because here's your prescription for your statin. Here's your prescription for your blood pressure. Here's your prescription for Viagra. I walked out with like 5 prescriptions. I'm like, why do I need these? Why do I need all that? I can understand the insulin, but I don't have any need for anything else. And so I was kind of surprised, but I wasn't given that information. And so I kind of walked out of there, and for about a week and a half, I just really had no knowledge what I was supposed to do. And I should clarify, it wasn't him. And so that kind of kicked off a struggle for me, but because of being a former lab tech and that experience, I knew it wasn't anything to mess with. So I took it very seriously. And I mean, right from the get-go, I realized that I needed to start making changes in my life to live and to live without complications. Because many family members that were type 2s, I chose terrible parents as well. And
You're not the only one.
No, probably not. Yeah. And I've lost friends over the years and through my life from complications of diabetes, and I didn't want to be one of those statistics.
And so you've had periods of taking better care of yourself and not taking as good a care of yourself. And tell us when you made great changes, because you're kind of a poster child. He's also got an incredible amount of energy. He sort of, when you find out what all the things he does, it's just kind of, it makes you feel inadequate. But anyway, back to you.
Well, when it comes to exercising, I fish. Fishing is a sport, therefore I'm an athlete, right?
Oh,
So
absolutely. Yeah.
we'll get that out of the way.
But when you to tell us a little bit about the transition from great self-care, from less great self-care to great self-care, and sort of what it meant to you in terms of well-being, your finances, what it took, what the challenges you overcame. Can you remember all that?
Oh yeah.
Oh, good.
Diabetes isn't cheap. As somebody with diabetes, it's not cheap to have. And that was one of the things in the very beginning that I had utter fear over, was how am I going to pay for this? Insulin isn't cheap, you know? And syringes and everything that went along with it, test strips. What do you mean I can only test 4 times a day? What if I'm not feeling right? What if I got to drive somewhere? And you know, you get these limitations from insurance companies, not just your own pocketbook. And so I really struggled with that. And talking with other people and whatnot, you see where people cheat on what they need to do. Oh, I only test twice a day. I don't test at all. Well, I take half as much insulin as I need. And I remember one time I was drawing up my insulin and I dropped the vial, my last vial, on the counter and it shattered. And I had to pay for a new one. What you're not also told, you know, from a lot of the different companies, you know, like my insulin pump, my CGM, that they'll replace, you know, ones if something goes wrong, but only a certain amount of times. And so if I'm out in the garden and I lose another CGM or I rip off another infusion set, somebody's got to pay for that. And it's not like you just call somebody up and they're going to send me a free box. And so, you know, I had to learn how can I make sure I have what I need to live right and also not go broke in the process. One of the things that I realized too is, and believe it or not, a lot of type 1s don't know this, that if you sit down and eat a meal and it's not full of carbs, you don't have to take a lot of insulin. Mm-hmm. And I mean, I've been at other events in the years where I've actually had people come up to me and shocked that Dr. Edelman said if I don't eat carbs with my meal, I eat meat and veggies, I don't need to take insulin. And I was like, well, yeah, but people don't have that information, they don't have that knowledge. And so for me, I was trying to cram all that in at one time. And so the key thing for me was, well, how can I reduce those needs on my insulin, my supplies? And so what did I do? I gave up the junk. I gave up the sodas. I gave up the white bread and a lot of that stuff. And initially it made an impact. I saw that benefits, but there were other things I wasn't doing, and that was the moving. And so once I did that, and it's almost 2 years now, I believe, lost 29 pounds. Unfortunately, since October, I've started gaining some back because my knee, which will get repaired on Monday, thankfully. But I started doing exactly the things that Diane was talking about. I work from home. I have a sit-stand desk now. If I have to go to the bathroom, I don't use the bathroom downstairs. I'd sprint up the stairs. I'd run back down the stairs. And I started doing that multiple times a day. And I found that it became easy and it became a habit. It wasn't a chore, it was something I wanted to do. The other thing I love doing is my bicycle, riding my bicycle. And I'm looking forward to having my knee done Monday because I can get back on it and find that as I'm enjoying that movement, without it being, I gotta exercise. Life was good. My insulin needs have reduced 4 times. I've cut them back that much. My insulin.
You mean you're taking 1/4 as much as you used to take?
Yeah. Taking a quick.
And how financially? What is that? What's the impact of that financially?
Depending upon which insurance plan I had and through over the years, that's thousands of dollars
a month,
a year. No, about a 3-month supply right now. Still, depending upon who bills it and what they're claiming, it's about $2,000-3,000.
Yeah. So cutting that by 3/4. Tell us about your kitchen time.
I'm the cook. No, kitchen is my playground. Everybody knows it. There's even a couple drawers in the kitchen. Those are Dad's. Nobody gets in those. People come to the house and they start opening. They'll say, "Don't get in that drawer," and that's my playground. And it's become my area to help the family and friends and extended family when they come over for barbecues, whatever that might be. That you're going to get what I make. Maybe not what you want, but you're going to get what I make. And it's had struggles. You know, I've found, you know, folks in the family sneaking junk somewhere here and there, but that's their choice. It's not their choice, that I want to make. But I found that by doing for me, for my family, has increased well-being there as well.
And what does well-being mean to you? In what ways do you feel better when you're taking better care of yourself? You're cutting your insulin by 3/4. You're cutting your expenses way down. What does that mean in terms of well-being for you?
No excessive highs and no excessive lows. I think as far as having diabetes, that's a big thing, because then you don't get on that roller coaster of trying to bring your sugar down. Oh my goodness, I got to bring it back up. And knowing, most importantly, that I have no issues. I have no complications to this day from diabetes. And I hope to live, you know, a long life and still be that way, you know, complication free.
Because lows are not, what are some of the complications of lows if you had lows?
Death.
Short of that, yeah.
Coma.
Yeah, short of that.
Car wrecks, loss of consciousness,
And seizures?
seizures.
I've got one patient who's a type A, type 1, and she just loves to have really well-controlled blood sugars, but she keeps seizing when she's traveling. And the thing is, when you do that, you actually get a little bit of brain damage. And so low blood sugars are not a unimportant complication, and therefore not an unimportant value for Jeff, in that he's got less brittle diabetes, more controlled blood sugars, with less concern over his actual insulin dosing, if I got that right.
Yeah.
What about for your family?
But it's pretty much a flat line, which in this regard is good.
It's all about context. What about your family? How's that? How's the impact on your kids and your wife?
Initially, it caused a lot of controversy. I'm not a diabetic.
Yeah.
Why should I have to do this? You're not today. You like me tomorrow.
Because you picked the wrong parents.
You got the wrong parents. And look at the family gene pool here. You know, it's not today, but you might tomorrow.
So helping your kids learn better habits earlier, or see them modeled anyway.
Very much so. Including telling them, oh, that's great. Your doctor said your labs were good. What were they? What were your results? What do they mean? That's the other thing I stress to them with those.
Yeah. And tell me about your neck, Jeff. I understand that you saw a practitioner some years ago, maybe a decade ago or more ago, and your neck's better.
Yeah. Diane wouldn't remember me, but Miles sent me to her. I remember that years ago. We thought I was dealing with carpal tunnel, you know, being the computer nerd I am. But it actually ended up being for my neck. And sent me to Diane, and I'm still to this day doing the same exercises, using the same, well, it's getting pretty worn out now, roll and everything else, and I've not had an issue since.
And you haven't had to have neck surgery?
No.
What a deal. So another Diane success story.
That's it.
Yeah. Well, thank you. Is there anything else, Shelley, that you can think of from Jeff?
Well, can you tell us about your hot sauce?
Which one?
Jeff makes his own hot sauce, and he brings them and he names them clever things like gastric assassin and Uncle Bub's.
Oh.
Uncle Bub's something.
Chicken sauce.
Chicken sauce and
yeah.
Dr. Dave's hangover cure. And
Yeah, that one's for.
he makes.
Dave,
He's
yeah.
a really good chef. Really
Yeah.
good. Thank you, Miles. Thank you, Jeff.
Thank you.
Thank you.
Thank you.
All right, so now let's get down to the practical aspect of this, the actual food. This is the fun part. And this is the part you don't need doctors or nurses for. And so what we're learning is that there is unnecessary suffering in the world. And doctors and nurses can't necessarily help. We can, but people don't need us. They might just need a chef's knife and a pan and some training, and it's amazing what can happen. So Kayla's going to talk with us about what to do when someone has barriers to getting in the kitchen and making their own food. Again, we've got beans and grains over here. to just highlight how affordable it can be to buy and make and cook your own food. You've heard about food deserts and food insecurity, and we've seen people really successful when they get together and find someone who has a car, and they all pile in and go to Winco and go to the bulk section, and this isn't just imaginary, this is actually real. So Kayla is an outpatient dietitian and certified diabetes care and education specialist at Providence Milwaukee Hospital's Community Teaching Kitchen. She completed her bachelor's degree in dietetics in California at California Polytechnic University, Pomona. At Caltech. She then moved to Portland, Oregon to complete her dietetic internship and master's degree in clinical nutrition at Oregon Health Sciences University. Kayla has a true passion for teaching others about food and nutrition. She gets to work in a kitchen all day, guys. It's so cool. You'll actually see her on Providence Milwaukee Community Teaching's YouTube site, Cooking in Real Life. They have videos in English and in Spanish there. It's a great resource. She finds it rewarding to build connections with patients as well as provide support in their journey to creating healthier habits and finding overall balance to improve their health. She enjoys working with patients to bring joy back into the kitchen by making nutritious food easy and fun. And what's interesting is we were invited to visit and to drop in on some of the cooking classes at Providence Milwaukee Teaching Kitchen, and Kayla told me about some patients who were referred there by their primary care physicians because they had one diagnosis of loneliness, and they were aging and didn't want to cook for themselves. And it's interesting what happened to their depression and their ability and their sense of community when they got in the kitchen. So Kayla, take it away.
All right, thank you so much, Shelly. And also thank you guys for being here today. I'm excited to be here with all of you. I will be sharing a lot about our program out in Milwaukee, the Community Teaching Kitchen. Raise of hands, how many of you guys have heard of us before? Yay, a couple of folks. I know we're on the east side of the river, so a lot of people don't necessarily know about our program. So I'm here to share that with you. I'm also here just to talk about what are some of the health benefits and also financial benefits when it comes to cooking more at home. And if y'all are providers or caregivers, how can we maybe coach our patients to, find the value in cooking more? So that's what we're gonna discuss today. Here we are. So as Shelly mentioned, I work at the Community Teaching Kitchen. I have been with Providence since 2016, so almost going on 10 years, but I've been with the Teaching Kitchen since 2017, so a pretty long time. It was like right after we opened our doors. And I found out about our program while I was working inpatient at Providence, Milwaukee as an inpatient dietitian from one of my patients. He was admitted in the ICU. He was admitted for DKA. He was a person living with type 1 diabetes. He was also facing houselessness and living in a tent in the backyard of his brother, or at his brother's house in the backyard. And he was being discharged, but he told the internal medicine doc, like, hey, I'm not going anywhere until I speak to the dietitian. She has what I need, get her in here. So I come in and I see him and I'm like, hey, what's going on? I heard you wanted to talk to me. And he was like, I need to get a food box from the Teaching Kitchen. Can you please help me set me up? And I'm like, the Teaching Kitchen? What? What's the Teaching Kitchen? So I ended up, he gave me a couple contacts. My patient gave me contacts, and I'm a dietitian at the time. And I messaged Heidi Davis, who's also my manager, and she was like, sure, come on down. We're in a medical office building on your campus. So I go down there. I see this beautiful kitchen that we have, this amazing food pantry, and I'm able to put together a food box for this patient based off of what his needs were. And from that moment on, I never left that place. I actually started volunteering and teaching community classes literally like within the next couple of weeks, and I have been there ever since. And as a dietitian, it is such a privilege to be in a space like that because I have so many resources at my fingertips. And I just want to share with you guys why it is important for us to talk about food insecurity and also some of our disparities or nutrition disparities when speaking about nutrition with our patients. So why are we here today, or why am I here today talking about nutrition? Well, it's because nutrition is one of the pillars of lifestyle medicine, and it is a very important one. There's already been so many amazing talks that have mentioned the importance of eating healthfully and incorporating in nutritious foods, and the reason being is because we know that food is a powerful tool when it comes to disease management, whether it's diabetes, heart disease, and other chronic conditions. The issue is, though, is that many folks don't necessarily know where to start, right? Traditionally, we might talk about, healthful foods or maybe certain foods that help with blood sugar management, and we give somebody a piece of paper, right? That doesn't always translate into actionable change, or at least sustainable change. Many folks are like, okay, great, here's the do's and the don'ts, but where do I get this food from? How am I gonna afford this? Is this gonna fit my cultural needs? Or is my family gonna be on board? So there's a lot of questions, and a lot of times that paper gets crinkled up, put into a bag, or thrown into the trash, and then we don't necessarily see any action from that. So I think it's important as providers that we are able to provide practical tools for patients to be successful. And a lot of times that's discussing culinary medicine, which we're going to talk about today. So before we talk about I want to say the sexy, right? The culinary medicine, we're going to talk about disparities and challenges. And the first thing I want to discuss is food insecurity. So what is food insecurity? Food insecurity is basically inconsistent access to healthy and nutritious foods. And I want you guys to understand that food insecurity exists on a spectrum, right? So one individual facing food insecurity, it might be completely different than somebody else. It could be, worrying, where am I going to get my next meal? So maybe skipping meals frequently if we're meeting with patients. It could be resorting to lower cost food options, maybe foods that are ultra processed, less nutritious, right? Because that's what we have available and that's what we can afford. Or it could be just the constant stress or worry, do I have enough food to get me through the month? Right? So that is kind of the level of, there's different levels of food insecurity, and I think it's important as providers that we understand that, and we're also screening to see where our patients are at. Because as we know, food insecurity doesn't just affect our bellies, right? We're not just feeling hunger or stress. It affects the whole entire person. And what I mean by that is folks facing food insecurity are going to be at increased risk of disease such as diabetes, heart disease, nutritional deficiencies, malnutrition, and mental health struggles, right? Anxiety, depression, just high amounts of stress in general. And we need to understand that. And that kind of results in those higher healthcare costs. So talking about barriers are really important, and addressing those challenges are also very important. So I have a picture here. This actually came from one of my patients a couple weeks ago. And he is someone who's been very connected with our program. He's been taking culinary medicine classes. He's been meeting with me individually. And he's been working really, really hard at kind of changing his overall just health. He's currently living with prediabetes, and so he's trying to just reverse and go the opposite direction here. But he's been faced with a lot of challenges. One being his SNAP benefits have been significantly cut. As many of us know, food prices are on the rise, cost of living is on the rise. And so he had sent me an email with this picture and also a picture of his refrigerator and freezer saying, hey, Kayla, I am at a loss right now. I'm feeling really discouraged. I feel like, I'm doing everything that I possibly can, but I've maxed out on my food budget. I have no more money left in the bank. I don't get my check until next week, and I don't even know what to cook or what to prepare. Can you help me? So we took a look at his pantry. He sent me some pictures, like I mentioned. I didn't provide the refrigerator picture here, but he had, I think, some lean ground beef in the freezer with some frozen vegetables as well, and then maybe some milk and some condiments in the fridge, and then here is his pantry. So I don't know if you guys can maybe kind of think of what we may have put together based off of this picture. or what might come to your guys' mind, but we put together chili. I think I kind of heard that in the back. But we put together a hearty chili, and it was something that he felt really, really good about, right? We used the spices that he has on hand. We used a lot of the beans because he has a variety of different beans. He has canned tomatoes. He had the ground beef in the freezer, also some vegetables. And not only did that meal, not only did he feel really good about that meal, but that was also something that he could stretch for the entire week until he got his check the following week, right? So you can cook it once and you eat it multiple days. So we both felt really good about that. But that's going to bring me to the concept of nutrition equity, right? Not everybody has access to send an email to their dietitian to say, hey, I need help. Not everybody has insurance and can see a dietitian, right? Not everybody has the knowledge with the foods that they might, or how do we use the foods that we have on hand? You know, it's not just about having food, but it's about that having the knowledge in order how to prepare that food. That is also very important. So I wanted to talk a bit about quality of food. When we speak about nutrition, it's not just the food in which we eat, but it's the quality of food that we are consuming. And that's particularly important when we think about managing chronic diseases like diabetes, right? I also want us to think about quality of food as a spectrum, right? Where, you know, nutrition again isn't black and white. Foods aren't good or bad. Everything is going to fit in some sort of way, but we do know that on this side of the spectrum here, minimally processed or whole foods are going to be more nourishing to our bodies, right? Those are going to be things like your fruits, your vegetables, your grains, and your beans, like Shelly's been talking about today. These are going to be highly nutritious, lots of dietary fiber, lots of antioxidants, phytonutrients, all that good stuff. These foods also tend to be lower in caloric value, but they keep us full for longer, right? They stay with us for longer periods of time. Whereas the other side of the spectrum are going to be our ultra processed foods. These are going to be things that are going to have higher calories, higher amounts of saturated fat, trans fat, sodium, added sugars, and not very much other nutritional value, right? Soft drinks, breakfast cereals, processed meats, those types of things. But I do want to point out that processed foods do fit within a healthy diet, right? So think about things like canned beans or canned fruit or frozen veggies, those types of foods, even your yogurts. We need to make sure that we can meet folks where they're at to make sure that we can coach them on how do we incorporate in more of these minimally processed options. So thinking about, I had a patient in one of my virtual culinary classes. She's really struggling with transportation. They haven't been able to get to the grocery store. She lives out in Malala, so there's not very many grocery stores where she lives regardless, and not very many food pantries. So the only food pantry that she's able to access out there doesn't have very many nutritious options. So I think she had like a can of chili with some like I think it was like frozen vegetables that were left. And that's kind of all she had to work with. That's all that she had that was left. But she was thinking, you know, if I take these frozen veggies and I mix it in with the chili and I try to add in, you know, I'm rinsing off my canned green beans too and adding that in there. I have an abundance of vegetables in this meal. Yeah, I'm eating the canned chili, but at least it's, you know, I'm not getting as much of that sodium as I would if I just ate the canned chili. She's thinking kind of as that plate method. Same thing with things like, you know, ramen, right? Some folks might only be able to afford ramen, but if you can like take out that packet, let's teach folks how to season it themselves. Maybe you add an egg with some frozen vegetables. I mean, you got a pretty balanced meal there, right? So again, when we're working with folks that are facing food insecurity, we got to get creative, and we also need to make sure that we're not being the food police and making judgment, but meeting them where they're at. So I just wanted to show you guys that quality of food definitely matters, but it does exist on a spectrum, and how do we kind of coach folks through that? All right, so let's talk a little bit about culinary medicine. How many of you guys have heard that term before? Yeah, a couple hands in the house. Okay, cool. So we're just going to discuss about why culinary medicine is important. So I'm going to start off with culinary nutrition. Basically, culinary nutrition is the concept of nutrition science, and then it marries culinary arts, right? So we are educating folks about nutrition and the importance of eating healthy, but now we're providing them with the skills to translate that at home, right? We're teaching folks how to maybe batch cook, we're teaching them how to saute foods up, how do we maybe meal plan, those types of things. Maybe we're teaching them how to cook vegetables, which is something that they've never in their life cooked before, right? But that is the concept of culinary nutrition. Now, culinary medicine is really where it gets exciting. This is where the magic happens. This is where we take culinary nutrition and we teach it in the healthcare setting. So it is taught by a healthcare provider. It doesn't have to be a dietitian. It could be a nurse, a physical therapist, a doctor, a PA, but basically they're taking, medical science, nutrition science, and then they're providing practical tools and skills that folks can cook more at home and have that better understanding of how do we actually take that information that's on a piece of paper and take it home into the kitchen, right? We do know that culinary medicine bridges that gap when it comes to knowledge and action, okay? It also empowers folks to, cook and create healthy meals. I can't explain this enough, but so many folks will take our culinary classes at the Teaching Kitchen, and they don't just learn from, us, they're learning from other people in that class, and it's really a beautiful thing. Culinary medicine classes aren't just for folks who don't necessarily know how to cook. I mean, you could be a home chef that has been cooking for 30, 40 years, but when you get a medical diagnosis, like say example diabetes, and you're asked to eat differently or think about food differently, it can be really, really overwhelming. So taking a class and learning about new tips and tricks or utilizing ingredients that maybe you've never heard of can be extremely beneficial and extremely helpful in our patients' lives. This also helps with adherence to making food choices, helps with food access. Most importantly, it makes cooking enjoyable and fun and exciting. It also kind of plants that seed for many families. Someone takes a class, they come home, they cook for their family, and then their family's like, oh wow, this is really good. Make this again, or let's recreate this and share it with other people within our community. So it's kind of like planting those seeds and seeing the flowers blossom. And most importantly, evidence even shows that cooking more at home and incorporating culinary medicine into practice significantly helps with managing chronic conditions. We see increases in biochemical metrics all the time, and we also see those long-term dietary changes that are sustainable. So a couple different pictures. I wanted to just mention that, you don't have to be working in a teaching kitchen like I do. We typically say that the teaching kitchen is like the Cadillac version, right? Where we have a built-in kitchen in our clinic, but it doesn't have to be like that. For those of you guys who are providers or caregivers and you guys want to teach a culinary medicine class, do it. It could be as simple as taking a wagon or like a tub just like this with a couple cutting boards, maybe a chef's knife, some measuring utensils and mixing bowls, and you can do like a cooking demonstration or even, do a small hands-on activity. Couple pictures that we have here, we popped up at a staff meeting and we did a hands-on culinary nutrition activity with a team. So you just need a conference room, just like the one that's right over here on the side, a couple outlets if you guys are going to be cooking using a heat source, and then of course some sort of hand washing station that could be close by. That could be as easy peasy as a restroom, right? So there's a lot of different options. One of the things that we're currently doing is we are partnering with Portland Open Bible Church. It is a faith-based organization in Southeast Portland. They also have a huge on-site food pantry and a really big gym that isn't really being used. So what we do is we pop up twice a month and we teach classes in 5 different languages that are completely free. So I wanted to kind of come back to that nutrition equity piece. Many people can't always access our program because it's insurance-based, right? We bill insurance for our program. So these are some free classes that we're able to offer in our community that's not too far away from our Milwaukee location. But this is a picture here where we're popping up and we got burners set up, we have tables and all the things, and we typically teach classes anywhere between 15 to 30 participants. So it's a pretty jam-packed class, and we're able to kind of partner with another organization. So there's a lot of like-minded individuals like us who want to do the work and feel or understand the value in this work. So partner with folks that might have that space or that kitchen space if you're feeling like you guys don't necessarily, or you guys aren't able to offer it. So there are different options. Even here, we popped up at like a demo. I think this was, I don't remember necessarily what this was with, but we did a demo. So even just doing like cooking demos here and there. Shelly used to do it at her clinic, at the women's clinic. So she's very familiar with kind of kitchen in a box and just trying to bring culinary medicine out into our communities. All right, so just really quickly, we'll talk a little bit about the framework for food as medicine. So again, it starts off with a patient assessment. This is what, for those of us who are providers, what we're already doing, right? And then we have the standard medical intervention. Now, where the food as medicine framework comes about is right here at this puzzle piece, where now you're taking your standard medical intervention and you're gonna pair that with a food as medicine intervention. That could be referral to a dietitian for medical nutrition therapy. It could be a referral to medically tailored foods. So these are foods that are going to fit an individual's diet prescription and are typically already prepared for them. Or you can even try to figure out what are ways that we can incorporate in culinary medicine into our practice or refer to a program that already does that. And the reason why this is important, because what research has shown is that if we can strategically and thoughtfully pair these two interventions together, we see a significant increase in lifestyle and behavior changes. And it translates to, again, improvements in our biomedical data, a reduction in healthcare utilization, and of course, like, patient experiences satisfaction. They love it. They have so much fun. And this is something that they carry with them outside of the clinic and into their everyday lives. And then again, of course, the value of investment, revenue generation, cost savings. But I think what's most important is really improving the quality of life for our patients and also providers. Like, come on, y'all. It's fun. It is really fun to teach a cooking class, even if you guys have never done it before. I think that we're able to kind of relate and engage with our patients on a completely different level than we would in just like a patient appointment, right? So it's kind of cool to have the option to do so. So I know I'm running a little short on time, so I'm just going to talk to you guys a little bit more about our program at the Community Teaching Kitchen. So we opened our doors back in 2016. We did so based off of a project, I believe that was being performed in the women's clinic, where they were screening and intervening for moms and their children in the Milwaukee area. What they found out was that there was a major need for food access resources, and they decided to start screening adults. And they were like, okay, well, we can't ask the question, right, without having the resource. So they opened the kitchen. And I like to think about our teaching kitchen as kind of like this wraparound food access model, where it's very unique. And I kind of think of it in two different arms. So kind of follow with me if you can. The first arm is going to be kind of where we have patient navigation, who screens all of our patients and basically for all of our social determinants of health, including food insecurity. So patients are referred to us. We are a medical referral-based system or program, but they can be referred for dietitian services, which is our other arm of our program, or for food access services, which is food insecurity. We have a beautiful on-site food pantry, or what we might refer to as a food pharmacy, that offers very healthy and nutritious options that can satisfy a lot of different chronic conditions. So our hope is that someone comes in, they're referred to our program, they are taking home a food box, right, that can satisfy for 3 to 5 days for their family, but it is going to be able to meet their dietary needs, whether if they have diabetes, celiac disease, heart disease. So that is our food pharmacy aspect of things. And then you have the dietitians, where we offer medical nutrition therapy one-on-one. We also have our culinary classes, which I'll talk about in just a bit. And we just recently ended up taking over the 48-bed and fruit orchard Garden of Giving, which is an on-site community garden at Providence Milwaukee Hospital. We did this through a health equity grant from 2022 to 2025. And this is great. This has been a great learning resource for our patients. We teach about kind of growing your own food. They're able to see it. They're able to engage in these activities. And then we funnel the produce down back through our program, either through the family market and then also through our classes. So we talk a lot about seasonality. And then of course, we also have a YouTube channel, like Shelly mentioned. QR code is right here. I also have some handouts if you guys wanted to check us out. So please, if you guys visit, like, and subscribe, of course. All right, so culinary medicine classes, this is really our bread and butter. This is what sets our program kind of apart from some other nutrition programs, and that is because we're able to offer these hands-on options. Now, we do offer virtual classes as well, so for folks that are here on the west side and can't make it on over to Milwaukee, no worries. We do also offer virtual classes. They're actually pretty cool. We've taught meal planning classes virtually, so it's kind of like we get to pop up in other folks' kitchens and we all cook together, and they're cooking from their pantry. It's like the closest thing that we can get to seeing how we're kind of doing within the home. But yeah, it kind of can satisfy the needs for many different folks. Folks are also able to take home recipe bags. So basically, you are encouraged to cook the recipe that we prepare in class, or, you can use the ingredients for something completely different. I think one of the biggest things, though, that our classes do lend is building that community and reducing social isolation. So as we get older, we tend to feel more socially isolated. Also, food insecurity can be very socially isolating. A lot of times when we get a new medical diagnosis and we don't have family members that are on board to make changes, we kind of feel overwhelmed and at a loss. But you can take a class and you can find folks that are going through similar situations as you, and that's kind of where you build that support system. Our classes are offered in English and Spanish, and for all ages and and they're disease specific. So kind of wrapping things up, we talked a lot about, cooking at home, and that's just because there are so many benefits, right? So our health benefits are going to be things like improvements in biometric data, so improved blood sugar control, better portion control. We tend to have a higher nutrient density when it comes to the foods that we're preparing ourselves. And this also helps strengthen other lifestyle habits. So if we're cooking more at home and we're feeling like we're eating well, we're probably going to be sleeping better, more motivation to exercise, right? So all of those 6 pillars of lifestyle medicine slowly but surely start to get worked on. And then of course there is this financial benefit as well. I just wanted to show you guys some pictures. These are some pictures from our patients. They love to send us the creations that they prepare at home. So yeah, just to wrap things up, you guys, these are just some practical tips of what you guys can do when you're working with your patients. Just make sure you ask questions, kind of see where they're at, and offer those resources. If we are screening for food insecurity, 211.org is great. You can enter in a zip code, and then all the food pantries in the area will pop up. But I'm happy to answer questions after today's presentation if anything comes up. Thank you.
So before I met Miles, I got to spend some time in women's health. I was a labor and delivery nurse, worked in lactation, worked in postpartum, and then moved over to the clinic setting and worked in prenatal care, covering some women's clinics on the east side and a couple over here. And I'm going to talk about reducing gestational diabetes rates in the kitchen. And there we are in the kitchen where we met Kayla. So the subtitle of this is I Need Help. And at some point, we all need help. And raise your hand here if you've ever needed help, like cleaning out your garage, or doing a project, or your pet got out, or there's problems with the chickens, or, okay? 2 people, thank you. I'm glad I'm in good company. Good. Just want to highlight, if you ever Google the staggering cost of diabetes, you'll get an updated, what is the staggering cost of diabetes? And yes, we do spend a whole lot of money on diabetes and prediabetes in this nation. I didn't realize every 26 seconds someone in the US is diagnosed with diabetes, and this was in 2022. But there's this harm, these serious health complications that are preventable. Most of them are preventable. So we're going to talk about human suffering. Like the human condition is to suffer. And something in you feels like there's something wrong when you see unnecessary or preventable suffering. So I'm going to tell you a little bit about my story with that. In our women's clinics, we wondered if the gestational diabetes rates were climbing as well as the overall type 2 diabetes rates. And in fact, they were, because we just felt like every year, year after year, we'd see more patients with gestational diabetes. And this is a couple of my nurses on my team. And what happened was the nurses kind of went on revolt, and they approached me and said, Shelley, we're the first people that contact a patient when they are diagnosed with gestational diabetes. And we tell them, here's what the path forward is like. You're gonna have to check your blood sugars 4 times a day. You have pregnancy-related diabetes, and you're gonna need more visits and maybe a subspecialist and probably a medication. And I'm gonna be calling you in a couple of days to find out what your blood sugar numbers are. And then you're gonna meet with a dietitian who will tell you about how many grams of carbohydrates you can get every day, and make sure you follow that. And we weren't really helping anyone get better. We were just making them sad. And so the nurses came to me and said, why do we feel like we're not helping? Do the patients and the doctors even realize there are side effects to insulin? It makes you gain weight. It causes more fetal anomalies. It complicates pregnancies. It's expensive. And the patients would hear doctors say, I'm not concerned about your blood sugar, I'm concerned about your baby. And in the patients, these vulnerable pregnant women carrying the most vulnerable population we have, I'm so glad there's a baby in the audience today, would just say, oh no, my baby's in danger, I'll do everything you say. But what we were telling them probably wasn't the best advice. So we kept increasing patients' insulin dosage as their pregnancies went on, and it was what I would just call unnecessary suffering. And we weren't able to help. We weren't helping make them better. So these nurses were not smiling at the time they came to me. They just said, we quit. We're not gonna make any gestational diabetes phone calls. You do them all. And so I thought, what an opportunity to have a period of discovery and find out really what's happening here. This little one here, she actually took a video of herself throwing like a temper tantrum, like a toddler, and every time she'd get mad about the diabetes problem, she'd send it to us. And we'd get on teams and laugh at her throwing her tantrum, and that's how we felt inside. So I noticed that there were a lot of papers in the medical literature on compassion fatigue, and I was like, what is that even? It's interesting if you Google it, it's like, oh, people are just tired of caring, like they've run out of love. What is going on here? There are all these papers on burnout and healthcare, and 40% of nurses are expected to leave the workforce by 2029. Like, people who are doctors, statistics will tell you, they're telling their kids not to be doctors. Like, what is happening here? Why are we burnt out? Are we just tired? And you heard about the nurses' health health study and the health professionals follow-up study that offers a good way to live as far as lifestyle goes. But what about this whole like, something's wrong inside? And then also this term professional dissatisfaction. And I was like, what is happening with these healthcare providers? And I realized there's a term that actually clicked called moral distress. And that's, there is something wrong, I can't help. And the system I'm working in isn't giving me the tools to actually do a good job. People want a better way to get better, and I can't give it to them. And so this is what was happening with these nurses. And this one said, like, Shelley, like, go to your source of truth and figure out what to do, because I'm like out of here. And I thought the same thing. I was going to become one of these statistics. And I actually envisioned myself becoming a Subway sandwich artist, because I thought, okay, they're artists, and customers walk in, they ask for a thing, you build it, you give them exactly what they wanted. So I was like ready to be done with the whole thing. And then I just like cried out, I need help, with the confidence that help would come. And so here's what happened. We just kind of started a study on gestational diabetes and insulin use. And we found that insulin use was, by itself, was a predictor of fetal anomalies like malformations and babies who needed surgery. And the big question we asked was, is our prenatal care even doing a good job? And the big gap we found was, we weren't asking patients, what are you eating? We weren't starting from the right place. So we weren't even finding out about them. There were other costs involved with gestational diabetes. We were sad about patients who had to make a change in their birth plan. They went in expecting this like perfect, beautiful gentle birth, and then gestational diabetes came along and like wrecked all their plans. And we were delivering that news with not very good solutions. And when you have a baby, you're writing this movie that stays with you forever. When we talk with some of our aging patients on hospice, these ladies will tell you about every moment in their birth. And all of this was just like really sad, and I can't stress enough with the risk of fetal anomalies, like the human suffering, the preventable suffering that was happening before our eyes, and we felt powerless to help. Unnecessary suffering. And we said, we need help. So we went with our librarians and did some studies about what actually works and what was something that nurses could provide. Because again, we couldn't sign orders for anything except prenatal vitamins, and we just felt powerless. And so we found a hands-on cooking intervention actually did move the target for gestational diabetes in the literature. So we thought about what our prenatal care could look like. And then we just, like we said, we need help, and we started meeting people, colleagues, and their resources who motivated us to like do something better. And so there was this nurse who worked in primary care, and I was like, can I just shadow you for a little bit? You guys do all this diabetes care. We're gestational diabetes. It's a little different, but you guys have like a program. And she just said, this is the book we use. And she threw the book at me and had me read it. And I was like, whoa. So has anyone had, like, in reading Good Food, Great Medicine, has anyone had this discovery where you're like, I didn't even know, I knew it, but I didn't know it. Like, yeah. So we started having this period of discovery with this book. And then I called Dr. Hassell and I was like, good book, but you don't have a section on gestational diabetes. Also, can I shadow you? And he said, sure. So I just followed him around while he saw patients. And what I noticed was he asked every single patient, what are you eating? And raise your hand if Dr. Hassell's asked you, what are you eating before? Christiane, raise your hand. Yeah. That's the first question. If the patient was having toe surgery, if they were recovering from a stroke, if they were here for their very first visit, like, what are you eating? And so I also said, you know, we really need a one-page handout on gestational diabetes. And he said, oh, we'll write one. And so we wrote one together, and he gave it to us. There was like this generosity that I just didn't understand, and I wasn't seeing it in the health system I was in. And his staff was amazing. Every time I'd have meetings and such over at St. Vincent's, and when I'd be in the building, I'd just wander into his office. Anyone else just stumble into Miles' office when you're in the building? Yes, all the time. And then Mia would wrap her arms around me and say, how are you? Can I get you some tea? And she'd invite me for lunch. And Lisa would say, you need handouts? Do you want to see our health history log? How about our food logs? You need some ideas? I can help you. And I was like, yes, we want all of it. And so if you look at page 81 in Good Food, Great Medicine, you'll see a section on gestational diabetes, and that came out with the 4th edition. And so Dr. Hassell was just generous enough to like build it with us. And then he joined us in rewriting the system literature in the Living Well with Gestational Diabetes literature that goes to every single patient that's in Providence Medical Group. We just got in there with the authors and the dietitians and had a collaboration on incorporating whole foods. So help came to us. And then this doctor on a bike, Joe Kemp, pedals into our clinic and he says, hey, guess what? Your medical director said you guys get to do continuous quality improvement work, and there's funding and resources for it. So pick a project. We chose gestational diabetes. And there's a little process we went through, and feel free to ask me about that afterward. But really what's at the middle of it is love. It's like people love people. And seeing unnecessary suffering does something to you. And I think that's really what this caregiver burnout thing is. Like, you're affected. And in going through our day and making waking up, exercising, eating our breakfast, going to work, clocking in, clocking out, you can go through your routine for only so long before this kind of like decay sets in, where it just starts to like erode your spirit. And we had lost our spirit because there wasn't anything we could do to help. So this helped at least give us a guide to communicate with our teams. We do these little huddles and say, here's how my project's going. At least this structure gave us a guide. Some posters and driver diagrams gave us a guide to just communicate with our manager, who again had seen real suffering. Our manager was a big supporter because she'd had relatives lose their limbs over diabetes. And like, that's tragic and it's preventable. So we had a lot of support, and basically we just said, what we want to do is reduce the number of patients with insulin-dependent gestational diabetes. Means you can't control it with food. We've tried everything else. That patient needs insulin. Reduce the percentage of patients by 10%. And we got laughed at. And they said, gestational diabetes rates are climbing. Risk acuity is climbing. You cute little nurses with your cute little kitchen are never going to do it. But we did it. And we actually decreased the amount of insulin-dependent gestational diabetes by 21%. And so we just used a reduced, refined carb, whole food Mediterranean pattern. Like, we dropped the ready-to-eat breakfast cereal and made beans and grains. And the evidence says that works well. We had 2 clinics, and then we added a third over a period of time. We just invited volunteers, people who are already interested in getting healthy. And we continued to collect volunteers until we had about 100, and then we started measuring things. We had a slide up in the lobby. I don't know if anyone's still there. Is this still up in the lobby? It got stuck after I left and they couldn't change it. I'm like, well, keep it up. We just said, hey, have a green pregnancy, cook breakfast with us on Friday mornings. Ask us how to join. And so in that, we had to really recruit the front desk and the patient navigators, one of them's here, to kind of tell patients about this. And so our biggest supporters, the people who spent the most time on this project, were probably patient navigators who meet the patient as soon as they learn they're pregnant and help them walk through their care, front desk people, and medical assistants. So the doctors and midwives could go about their day, continuing as they were, and we just like wrapped people in a big culinary hug. So what it looked like was one of our clinics was right next to the Milwaukee Teaching Kitchen. So we checked our patients in a group setting, and once they were all checked in, a little medical assistant helped them with vital signs, and then we all went on a walk to the teaching kitchen. And we got in the kitchen, and we asked women, like, what is it that you want to cook? And so part of our discovery period, we asked, what are your biggest barriers, and what do you like to cook? And one patient said, well, breakfast is hard because I wake up, I'm hungry, but I'm nauseated, and I have to have something that like digests easily and is ready to go, is affordable, and won't make me throw up. And so she found that Cheerios were the thing. So she'd carry her box of Cheerios to every prenatal visit and work on them, and that really helped. Or so she thought. Well, she wandered into the teaching kitchen with us and brought her Cheerios, and we made this beautiful crackpot cereal with rye berries, hulless barley, and oat groats. I think we used a rice cooker because we didn't have anything else that would heat up water. And it was fall, so we made a pumpkin spice version with some pumpkin spices, pumpkin seeds, and a homemade whipped cream. And she threw that box of Cheerios in the garbage and left it there. And another lady said, well, I make the best peanut butter and jelly sandwiches, and that's the thing that helps. And I need to keep my peanut butter and jelly sandwiches. And we said, well, let's make this same bowl of crackpot cereal. And we made our own jam with some berries and chia seeds and lemon and honey, and ground up some peanuts, and we made our own nut butter jam and put it on top, and she loved it. We taught some knife basics, and then, so that Milwaukee clinic was like really, was able to take advantage of this teaching kitchen, and there's Chef Martin teaching me how to hold a knife correctly, and I never knew I hadn't held a knife correctly, but now that I'm using my pinchers, I have this callus here, I'm so proud of it. And so that was great for a Milwaukee teaching kitchen site, but we had an East Portland location and didn't have anything but a break room. And so the teaching kitchen folks put some tools in a box and sent a volunteer and said, well, let's set up in your break room. So we invited patients in. The ones who were waiting in the waiting room could smell the food cooking, and so we'd invite them in, bring out little plates to the waiting room and say, you want to try this? And the staff really loved it too. And then another option was, one of our clinics was close to the Providence Guest House, and in their basement they had this beautiful warehouse or like culinary dream kitchen. And so we popped in there and combined forces with them so that our pregnant women could walk over and the patients who were having cancer treatment could join us in a culinary class. And that was their visit. That was like a billable visit. One patient said, I love the breakfast burritos at Taco Bell. They're affordable. Like, I don't know, there's no way you could beat the price of a breakfast burrito from Taco Bell. And so we got our little griddle, we had patients cooking eggs. In this one, we had a dad come in and like took a saute pan, and these dads were awesome because as the baby's growing, that's 9 months of like, clearly the mother's doing something for that baby, but the dad hasn't gotten to like parent yet because the baby's not here yet. And so when the dads got in the kitchen, they like started to express themselves and show off their talents. And then they were able to clearly like do something to parent this baby before it was born. So anyway, we made this like breakfast burrito bowl with eggs and black beans and greens and stuff. And we were able to beat the price of a Taco Bell burrito, and the patient got to take home leftovers. So that was cool. So then we started to smile and feel a little bit like Kayla. Like when we started to meet these people with energy, we were like, oh, there is hope. There's hope for us. So our test group of patients, I want to say the most important thing is that we eliminated unnecessary suffering, which is huge. And this graph shows a little bit about the metrics that we were measuring: anemia, your oxygen carrying molecules in your blood, there are fewer of them, and lots of times it's an iron deficient anemia in pregnancy, and it was a marker we were trying to improve. Our patients had less anemia, less gestational diabetes, less insulin dependent gestational diabetes, and there was only, for the group, there was only one C-section, and she had already planned the repeat C-section. And so less surgeries, fewer unnecessary surgeries. So my question is, why isn't everybody doing this?
Actually, can I just interrupt there for a second? Her program essentially eliminated gestational diabetes, or at least insulin requiring gestational diabetes. Well, no, it eliminated the problem. So did the whole healthcare system get behind this? No. Why not? Why didn't the insurance companies get behind it? Can you imagine how much money they would save?
It wasn't yet standard of care because it was just too new and it wasn't traditional understanding.
But it's not. It actually. This actually teaching goes back 100, 120, 140 years.
And you don't need a doctor to do it.
And so I would argue that it shows something sick within our culture, and that's what GreatMed.org is trying to change. And it's what each one of us as individuals, in our individual cooking decisions, our individual buying decisions, and how we talk to other people and how we handle each other in our family, because these are metrics that would save society billions of dollars a year, save kids from having lifelong struggles. The presence of your mother having diabetes increases the risk of the child's obesity lifelong, and so on. And so the moral implications of what Shelley did are huge, and I don't want that to be missed.
And the patients took this back into their own hands. It was everything that the patient was doing. It's nothing we could have done. Keisha.
So I am a patient navigator from this clinic.
Keisha was here and did this project with us. Mm-hmm.
And I was pregnant twice with Shelley as a nurse. And I had GDM twice. The recommendations between 2015 and 2018 for how to care for GDM, they went from doing metformin or glyburide management to insulin as the first line of management.
So what Keisha's saying is she had gestational diabetes with 2 pregnancies while she was working at and a patient of our clinic. And the first pregnancy, they recommended some oral anti-glycemic drugs. And the second pregnancy, they recommended straight to insulin because the governing body changed their recommendations.
Right, and the nutrition management program was the one of, here's how many carbohydrates you can and should eat daily while pregnant because you need your carbohydrates. So Shelley and I were inspired by my experience. I declined the insulin. I said, well, if 3 years ago I I was able to do this without insulin, I declined. You'll have to give me a different option. So they had to deal with that. And then Shelley and I started asking for help.
Yep, we started asking for help. And we had women who said, I'm a patient in your clinic and I've had gestational diabetes with my first child. And we understood what that meant for childhood development outcomes. But she joined our green pregnancy program and she did not have gestational diabetes with the second baby. So again, we had no anemia. The average hemoglobin, which is an anemia marker, at admission for our patients prior to this was between 9 and 11, and for our group, it was 12. I think that's because these patients were open to an omnivorous whole foods diet, and if they hadn't been eating red meat before and weren't religiously objecting, they were open to it. We had no gestational diabetes. None of their babies went to the NICU. They had shorter hospital stays, no fetal birth injury. And there's this technique that doctors do when you have what you call large for gestational age baby. And that's one of the risks of gestational diabetes, where they dislocate the shoulder to move the baby out. Or they panic and have a C-section. And so this is a preventable injury. This baby never had to have a dislocated shoulder or a C-section if we could have met the woman right at the beginning of her pregnancy. And we did a survey about patients' confidence in the kitchen. What is your perceived confidence in making your own food? And they improved their confidence over this program.
Actually, Shelley, can I interrupt one more time? Can you go back 2 slides? So, I don't know if any of you have had a child in NICU. Yes. But can you imagine not having had to go through that? And her program also eliminated, in those 100 patients, 0 NICU admissions. Once again, huge financial cost, but even huger, more huge, you know what I'm trying to say, moral cost.
Mm-hmm. Yep, all right, so next we are going to write down your questions that you had for the speakers, and we are going to bring up Fawn Wolf. We talked about being like good cop, bad cop. I wanted to be good cop, but I think Fawn Wolf ended up being good cop, which is not fair. And Miles is going to talk with Fawn Wolf about like when is it appropriate to give up. I would say never. Like the people who were with me in this program said like she'll stomp her foot. Never. It's never appropriate to give up. But they're going to speak from that perspective. So welcome back, Fawn Wolf and Miles Hassell.
Well, thanks, Fawn, for being here.
Thank you.
Because you bring some actual expertise in the area. Among the rest of us who are just fumblers. And once again, because everything that Shelley talked about also translates to the bigger world of adult medicine as well. So there's actually no disparity between, in a sense, the moral imperative of treating GDM right or treating adult type 2 diabetes right. But it's particularly interesting to think about in the GDM world, the gestational diabetes world. You're dealing with somebody who can't take care of themselves, right? And that should add an extra little incentive to us. So, Fawn, when do you give up?
Well, how do you define giving up?
Good point.
Right? I don't know. I mean, I think there's certain circumstances, certain disease states that are going to warrant pharmacotherapy. You know, so absolute insulin deficiency is a clear one. Type 1 diabetes. You can't just tell somebody with type 1 diabetes, just make better food choices, just exercise more. That's just not the reality of what that disease is. So absolute insulin deficiency, I think, is a reason that we need to use pharmacotherapy. I do struggle with that fine line of when do we keep pushing for the clearly preferable approach of lifestyle changes versus when do we say this isn't working right now, let's use medications at least temporarily because our top goal still has to be to get some of these metrics down, but we're going to keep revisiting it. So just because maybe we start medications doesn't mean we say we're going to use medications the rest of your life. Unfortunately, that's often what ends up happening. But you know, there is the option of saying we can use medications temporarily, but we're going to keep working on what's actually preferable, which is to improve the underlying health so we can get you off the medications.
Yeah, I agree with all that. I remember, I don't know if any of you who know a gynecologist called Rose Blackwell. And she called me up once and said, Miles, would you, she's from the South. I can't do a Southern accent, but would you leave that poor lady alone, referring to a very sick patient of mine who I was trying to get to take better care of herself. And Rose recognized that this lady, she had big problems that weren't going to get better, regardless how much broccoli I got her to eat. And I was kind of, the word mean might be too strong, but you get the idea that, there's a point where even I should, who's sort of the bad cop side, should quit bugging people. And obviously somebody on hospice, that kind of thing. But there's this gray zone, I think, for all of us, where it's a person who's actually in reasonably good health, who could actually do quite a bit for themselves. But for whatever reason, family issues, cultural issues, taste issues, and that's, I think, what we all struggle with. So then the issue is how do you navigate that? And I think for me, you keep giving them drugs, and you keep counseling them. And so I think that you keep counseling them and you don't give up in that regard. So I don't know if we actually have different positions or not.
I don't think we do. I really don't think we do.
I'm probably harsher, I think, to my patients. Occasionally I fire a patient. Do you ever fire a patient?
I haven't.
Okay, yeah, so that tells you something. It just doesn't happen very often, but every now and then you're saying, this isn't working. You actually don't want to actually hear my wonderful advice, priceless advice about broccoli and crackpot cereal. And so that's what you actually often that's my sister Mia, the co-author of the book. Yeah.
I like you too well to see this happen. You don't just say, you're not doing what I say. You're saying, I can't watch this. Please find another provider that doesn't mind or that is someone different. And that's very different.
Yeah, the idea that you're actually watching somebody decay before you. Decay in terms of vascular disease, their kidneys are gradually getting worse. They're heading towards dialysis in not too long. They're one CT scan contrast away from dialysis. They're losing circulation in their legs. We're starting to have trouble getting their wounds to heal. We're worried about amputations. Maybe they've already had an amputation. I think that's what Mia is referring to, and of course I think for both of us, our patients become our friends, and so that's an important point. So I guess we don't have all that much to say, huh, Shelley? Are you fun?
Does that mean we're all the good cop?
I guess we're all the good cop. It's just I guess I'm a harsher version of the good cop. I guess one thing we could talk about is just, I don't know if people have better ideas on how you motivate people, because we're looking at these the issue is motivation. I have a patient right now. She drew a lot of bad cards in life, and she has these terrible mouth sores related to a variety of conditions she has. It's making it hard for her to eat, and she's so concerned about other members of her family, she actually can't bring herself to adopt the kinds of things. There's some mouthwashes you can use for the condition she has. And she can't take her attention away from the other things that are distracting her to actually help herself. Is that a fair way to express her situation? And that's kind of challenging because she's not helping herself, but she's not helping herself partly because there's a whole lot else going on in her life, not just her own malignancy.
And Dr. Hassell, because you've chosen to be a private practice, independent provider, you can take as much time as you need to try everything in your power to find resources to help her. And when she won't help herself, I guess that's when you give up.
Right, but I don't, unless they're actually decaying in front of me and somebody else could do maybe a better job, those aren't the people I fire.
And that's the same thing we're trying to do with greatmed.org is voluntarily we want to make this world a better place. We want to share with people a better way to get better. And so that is a picture of kind of what our aim here is today. So I'm going to bring down our other speakers and we're going to have a little Q&A and find out more motivational strategies. Maybe Diane probably has a way to motivate patients. I'm sure Kayla has a way to motivate patients.
I don't know about you guys, but when she was talking about doing 50-meter sprints in the pool, I just thought I'd walk right out under the door. I wouldn't even have to open it.
And I like her idea about sit stands. That's just sitting in a chair and standing up without your hands. And that's actually like, what is it? A measure of health and fall risk. And so do some sit to stands. Okay, questions. There's one right here.
So I was listening to the presentation on gestational diabetes, and I thought as a 70-plus-year-old man, didn't have much to do with me. But then I recall that our daughter is a nurse midwife, and she talks about all these problems. So how can I connect her with resources and help?
Greatmed.org. There's a website, and at the bottom of the website is all of our information. On greatmed.org, we have a resources tab, and there is a type 2 diabetes reversal clinician guide where they can go to it and look at all the evidence and all the research. And then they can build confidence that we actually use 3 lines of evidence. We do extensive research. We have quite the supportive clinical advisory board where we're working with other experts on our material, and then she can check it out for herself and see like if we're actually bringing evidence-based lifestyle tools. And then on that same website we have patient handouts, so for free she can just print out handouts for her patients. She can ask her medical assistants and her nurses to have the computer queued up with one of our quick YouTube videos for the patient to watch while they're waiting for their doctor. She can give patients our podcast handouts that you'll find on the table on the way out. Walk, don't run to the doctor. And lots of times patients will enjoy hearing just a 15-minute blurb on type 2 diabetes reversal, gestational diabetes reversal, things like that. And just have her call me. Greatmed.org, at the bottom there's our text, our phone, email, all that.
And greatmed.org is what the financial support that is the reason we have that at the greatmed.org is because of financial support that Larry was talking about. That's where the real machine is that we're hoping will provide information at no cost to everybody around the world, at least for now, who speaks English.
One right here.
Do you have information for after the baby comes out and mom has had a long run of hand-holding through gestational diabetes, and then the first question that gets asked, I work with babies when after they're out and mom has been able to now eat whatever she wants because there's not really any guidance. So my comfort level is I kind of joke with them, I'm like, what's your first meal that you had after you were in diabetes boot camp? And so we talk about food that they are eating. And I think there's some fear on what they can do going forward. Sometimes there's issues with low milk supply that might be
So we have
for them to.
Yeah, we have a great, wonderful question from the lactation community, and I don't know if there's a more important effort than helping moms feed their new babies. I don't know. I think that's one of the most important efforts out there. And so she asked for a patient who's been in like gestational diabetes boot camp during the pregnancy. She's envisioning like, as soon as this is over, I can eat like I want to eat. I might ask Von Wolf about what happens down the road when they do return to eating how they want to eat.
Yeah, can everybody hear me? The mic is okay. Well, I like what Miles said earlier, that we really, it'd be nice actually to get rid of the diagnosis of prediabetes and just admit that it's all on a continuum. So you might be earlier on the continuum with prediabetes than you are with full-blown diabetes or maybe insulin-requiring diabetes, but it's all a continuum, and I would put gestational diabetes on that continuum as well. So if you have a history of gestational diabetes, you should consider yourself on that continuum. And so if you don't continue those practices that were helping to control your blood sugar and your weight gain during pregnancy, you're going to move forward on that continuum. The nice thing, and I talk about this with patients all the time, is it's not a one-way street. So this continuum is reversible, which is what we've been talking about all day. You can move forward on it, and then you can move backward on it as well. So, but I think the emphasis needs to be there that this was not just a pregnancy-related diagnosis. This is something that manifested during pregnancy, because pregnancy is a time of relative stress on the body. And so you could be chugging along, doing okay, not pregnant, and then you're pregnant, all sorts of things manifest. But this is indicative of underlying pathology, unfortunately. So we really need to treat a history of gestational diabetes just as we do prediabetes, just as we do early mild diabetes. It really should all be in the same bucket.
I think we missed an important part of the question, which wasn't asked, but this celebration meal, this idea of a celebration meal. You've just had a baby, you've done well, the baby's here, you've had gestational diabetes. I know Jeff talked a lot about things he removed from his diet. He no longer did bagels or muffins or pasta, but what he added, if you could see some pictures of the things he cooks, this man can cook. And on special occasions, on his birthday, he has 2 servings of meat smoked like for 24 hours with extra hot sauce and so many more vegetables, and they're like delicious. And so can anyone comment on like a celebration meal and how often you have one? Is it a thing?
I think also just to add to that, I think having those conversations about changing, how do we think of as treating ourselves? You know, I have a lot of patients that say, well, I've been good all week, I'm going to treat myself with like a Frappuccino or something like that. Can we reframe what it means to treat ourselves? Can we treat ourselves with something that's going to be fulfilling to our, to our bodies and to our minds, and actually do good for ourselves, and just reframe that so that we're not thinking in terms of restriction versus treating. Yeah. I'm sure you have more to say about that.
No, I was just going to say exactly that with just the terms of restriction, right? A lot of times when we put labels on foods like good or bad, that can definitely kind of send us down that avenue of like, oh, I failed. And just knowing that something that you do one time isn't going to, make the big difference in the scheme of things. It's really what you're doing most of the time, right? Are we focusing on a well-balanced diet that has high nutrition quality, right? Kind of like what we talked about today in multiple presentations. And that's really kind of where we see that progress. So, yeah.
And secretly, I wanted to ask Miles about his cinnamon rolls.
Come on, let's hear more.
And I would, I think getting inside people's minds, and one of the things, this is a totally self-serving comment here, but if you can get people to read the first 100 pages of Good Food, Great Medicine, and hoping that they wrap their mind around the huge benefits of just cooking at home and cooking good food, I think.
We are all over TikTok. Yes. Check out the 6 apple challenge and give it to her. Yes.
Yeah.
Nancy.
What is the 6 apple challenge?
You're looking at me? Okay. So I don't know where it came from, but the 6 apple challenge is.
I'll tell you where it came from.
Where did it come from?
Do that, and you take it from there?
Yeah, I can't remember.
Okay, speaking of TikTok, we saw this doctor on TikTok who said, look at this apple. This apple has been genetically modified. It's not even the same apple as your great-grandmother knew. Apples are bad for you. There are 30 grams of glucose in this apple. You know what your problem is? It's not cutting out pizza. You need to cut out apples. And we said,
that's nuts. Because epidemiologically, we have multiple studies showing that people who eat more apples, fruits of all kinds, have less diabetes, less health problems overall. And so apples are not your problem. The guy who was saying all this does have a supplement to offer that you can get a subscription for, and every month he'll get another bottle, and he'll just take it out of your credit card. You'll never notice. It's great. Anyway, so back to the 6 apple challenge. So the idea was, how do you get people who are eating more than they should to eat less calories, eat better without being hungry? And so there's 2 big elements that you can do. One is more low calorie density food that has a lot of fiber in it. And the other is protein and fat. And so, but if you eat too much protein and fat, you're going to get chubby. So that by itself isn't going to. So if you start with the 6 apple challenge, pretend that every morning, let's pretend you need to lose weight. And every morning you start with 6 apples. Doesn't have to be apples. It could be 6 bananas. It could be 6 stalks of celery. We don't really care. Could be 6 hunks of broccoli. It just has to be more than a sprig of parsley, okay? It has to be something substantial. And then before breakfast, before your morning snack, before your lunch, before your afternoon snack, before your evening meal, depending how many meals and stuff you have 1 or 2 of those whatevers. People get really hung up on, does it have to be apples? No! And you're gonna eat less. And so we recently had a patient come in, and she had really been struggling, so we described this to her. And next time she came in, she had lost 2 pounds a week for the last 2 weeks, so 4 pounds down in 2 weeks. And because of this 6 apple challenge, and she hadn't realized she was just eating too much, and it gave her a way of feeling satiated. And so for the patients that are eating 6 apples, and they're still not full, because 6 apples aren't as satisfying as some things that we won't mention, but then you start adding a little bit of protein. So have your apple and a piece of cheese for your afternoon snack, and suddenly you're full, and you're not going to eat something else, like that cinnamon roll. That was really mean of you to bring that up. So So that's the 6-apple challenge. I hope that makes sense. It's just simply a spatial, so filling the space in your stomach with something that's actually healthy that will keep you from eating something else.
And it's interesting to experiment with this because you'll recognize how much chewing you do in a day. And when your jaw is tired of chewing, you're like, I'm full, I'm done eating. How much effort it is to peel an orange and section an orange and eat it, and then it's messy, and then you've eaten. Your body's like, oh, I've eaten something, I'm okay. So you don't have that panic urge to reach.
And it's doable, unlike sprinting 50 meters in the pool.
Well, what I was just going to say, though, what if we tagged on a challenge with your 6-apple challenge, and that would be to do 6 sits to stands, or while you're eating your 6 bites of whatever you're eating, you're doing some high knees, or you're doing some sort of little bit of motion. So you could make that a collaborative effort. So
Yeah, because along the same lines, we had a similar patient who came in who was suddenly successful. He'd been trying to lose weight, hadn't lost weight, and he was really struggling and had high blood pressure, wanted to get off his blood pressure drugs. And suddenly he was making progress. We said, what changed? He said, I started doing this. Every hour I did this for 1 minute.
not while you're chewing or swallowing.
Not while he was chewing and swallowing, right? Yeah.
And he traveled a lot, so he did that in the airport, and he didn't mind being embarrassed. We had one right over here.
Yeah, I totally understand the idea of reframing treats and all that sort of thing. But I think in the name of sustainability for folks, like, how okay is it for people to say, okay, I get one cheat meal or one cheat day a week, you know, hey, I want that bagel cream cheese lox, I want to have that birthday cake that, you know, at the office celebration, like, is that okay?
So as far as indulging goes, what do you all say? Does anyone want to take that one? Come on.
I would say the healthier you are at baseline, the better your body can tolerate those occasional treats, and it's just going to be like a tiny little speed bump. So patients will be amazed, you know, because in the beginning of their course, they'll say, oh, I ate, you know, a piece of white bread or a piece of cake, and I saw my sugar shot up to 300, and then it came back down again. And then if we get them to a point where their blood sugars are better controlled, more stable, then they find, I can have the occasional piece of white bread or cake, and I don't go as high as I used to. So I think it's all about where you're coming from. If you're really poorly controlled, then any little treat's going to shoot you off the charts. But if you're well controlled, if you're in a state where you're in pretty good shape as far as blood sugars go, then you can actually tolerate it pretty well. So it's hard to come up with an exact, once a week, once a month. But I do think it's good to not try to be perfect. You know, it's good to allow yourself indulgences for special occasions, for your birthday, for your, a major holiday.
And I think celebrate it, right? Feel really good about it. How we talk about food and how we view food is really important. And a lot of times when we call things treats, that's when we start to feel like, ooh, maybe this wasn't so great for me, right? So just know, like, hey, if I'm gonna enjoy a birthday cake at a work gathering, this isn't something that I'm doing every day. I'm gonna eat it mindfully. I'm gonna enjoy it. I'm gonna savor it, right? I really like what you said too. You know, when we're in a certain stage where we're feeling like we're eating healthfully or we have our health in check, a lot of times, food choices become a little bit more natural to us. It just takes a bit of time to get there, right? We don't want to feel like we need to restrict ourselves all the time, then that sends us through that diet loop, right? So we have to kind of,
I think it does need to be intentional too, because it can, I mean, I don't know, at my office, we're celebrating something at least once a week. So something's being brought in, and you've got like a cousin, a second cousin graduated from 4th grade. Like you can't, So you have to be intentional with it and be like, okay, I'm gonna allow myself treats for the things that really matter to me.
Yes.
But you have to think about it. You have to have intention.
The thing that happens is this transformation process that happens when people start eating better, they start feeling better, and you see this transformation happen where they don't want the things they used to want. Their appetites change. They don't want to feel yucky and fatigued anymore, and so they don't want the same things. Like I joke about the cinnamon roll, but I think Miles really enjoys indulging in a piece of toast a week that was ground. He ground his own wheat in the mock mill, and his wife baked the bread, and like he really relishes that piece, one piece of toast with like really good butter. Jam on there, butter.
Maybe even 2.
I mean, maybe a piece of toast is indulging for him, because once you go back and eat cake, if it's been 2 years since you've had a piece of cake, you feel pretty bad. So the neat thing is, like, people want to feel better, and then they don't want to enjoy the same thing. They don't find it enjoyable, the things they used to enjoy. That transformation piece is kind of neat.
It has not been 2 years since I've had a piece of cake, just saying in terms of honesty here. And secondly, if you do indulge and you have type 2 diabetes or type 1 diabetes, for example, that's the time to actually think about, wow, I'm really enjoying this. and I'm going to do some exercise right now. Jeff, you probably have had that experience where you've had something you knew would shoot your blood sugar up, and instead of taking extra insulin, you exercised. Am I right?
Yeah, but I hardly even do that anymore because it's just, I don't have a craving.
But it does work. If you did, come on, play along with me, Jeff, here.
That's what I actually used to do. Was just, for me, it was an excuse to have it. You know, but then it became a thing of, it was just, felt like just.
So you do change your taste, your desire for this stuff. But if you do, and you're really enjoying that cinnamon roll, like a friend of mine does, then doing that exercise after you've had it will give you a double whammy, because you say, wow, I enjoyed that cinnamon roll, and I'm virtuous because I exercised.
And in Miles' defense, when I saw him order a cinnamon roll, he ate about a fourth of it and pushed his plate away and thought, that wasn't as good as I thought. So, yeah.
It wasn't very good.
But I've got to be honest. I'm going to be totally honest though. As a type 1 and learning how to count carbs for that garbage, it's easy to have it. Because you know, I can get my sugar down, but you're still eating garbage.
So Jeff mentioned that even if you're counting carbs, you can still be eating garbage. Even if it's organic, it can still be garbage. Even if it's gluten-free, it can still be gluten-free garbage. Christiana.
Why don't you have a camp for a week or 2 or 3 with all the people who explain exactly, I am not American. I try to understand everything and I'm fighting like hell. And I'm not getting there.
Christiane wants to fund a 2-week camp. Thank you, Christiane. That sounds like fun.
Well, something to help you to do the right thing.
Christiane's our token Belgian.
Well, behavior change is hard, and I think you point out a really good point. It's so easy to gather the information, but it requires partnership across this whole network, and it is hard to make appointments with each individual person, carve that out. So I appreciate what you're saying about that.
I have a room here at the hospital that I paid for, and when I see how I was treated, I'm getting mad. And no one listens to me.
And that's exactly why we're here.
Hey, Karen, is the service you provide, would that fit into what Christiane is talking about?
So Karen, you want to tell us about local roots? So we don't like excuses. Talk about excuses and then hand it over to Karen.
So talk about it.
Talk about excuses. Like when patients say, I can't get beans and grains, we sell them, bag them and sell them out of our clinic.
Yeah.
I don't have a way to get to the store. We say, do you need a ride? Hop on the bus. And when patients say, I can't cook my own homemade food.
Then we got Karen. Karen, can you tell us a little bit about your service? Because this may actually, this may relate to Christiane's question. I don't know if it does. Tell us if we're getting there, Christiane.
So I started as a family chef, and I decided I wanted to make my business more accessible, more flexible. And so I have a meal kit and meal prep delivery service. I have a team. We rent space in a kitchen in the Portland area, and we make whole food meals from scratch and deliver them to people's homes. So I think, there's so much that we can't outsource, in terms of our health. Like, nobody can exercise for us. But meals, that is something, it may be a period in your life, like right after you have a baby, or recovering from a surgery or an injury, or you're at that point in life where you just can't cook from scratch at home anymore. So that's why I do what I do. I love the book. I've given it to many clients. I kind of have a Mediterranean diet foundation, and feeding people is what I love to do, and that's my business.
So Christiane, for the challenge you're facing, maybe hooking up with somebody like Karen might be until we get our 2-week
I cook
plan.
myself. I cook everything myself. The question is, what to do exactly to stay healthy, not to have more problems, because every time I have something else. I don't want this.
Yeah. Well, why don't we could talk offline after we're done here. Yeah.
And for our checkout team, they'll meet you at the table if you have to slip out early. So I'll release you to go ahead and do that. But we had lactation raising your hand again.
Sorry, another question. I appreciate the courage of you speaking up in the front row, because I was thinking about the buy-in and having to meet patients and where they're at, and affinity groups, if that's anything that you guys are thinking about, or social media where people can communicate within their own ways that are comfortable, because it's really hard to ask for help when you're always the one saying, I need help, and sometimes that's not comfortable within our system.
It is really hard to ask for help, and that's another thing greatmed.org does. We have some patients, or some friends who use our resources on the East Coast, and one lady will just send me her weights every week and say, I'm down a pound, I'm down 1 pound, I'm down another pound, I'm down a half a pound, or I'm stuck. And that's another resource we provide as far as just general advice. I saw a hand way back here. Yes. Yes.
I was wondering if you could address glycemic indexes.
Glycemic index.
And how that should affect our choices.
And
I'm
how
not
it
talking about ultra-processed foods. I'm
And
talking
how-
about whole foods and glycemic.
How should glycemic index affect our choices? Who wants to take it?
I'd be glad to start. I think it's a waste of time, most of the time. So, for example, if you're not eating ultra-processed foods, does glycemic index matter? And I think our research fails to show that it really does. Glycemic load does, so the total amount of carbohydrate you eat. And so I would argue that if you're eating a high glycemic index food and you care to lower the glycemic index, have some fat or protein with it. But in general, if you're eating whole foods and not eating too much, you're not going to have to worry about glycemic index.
I agree.
And that's where, for example, people eat a banana, right? And they've got a freestyle, CGM, and their blood sugar goes up. I said, well, my blood sugar would go up too. I wouldn't measure it because it doesn't matter. If you eat 6 bananas a day, is your weight going to go up or down? Is your diabetes going to go better or not? What?
Your weight's probably going to go down.
Yeah, exactly, because it fills you up. How much calories does a banana have? 70 to 100. How much calories does a Costco muffin have? 500 to 700. How many bananas can you eat? 1 or 2. How many Costco muffins can you eat? With coffee? Too easy. So I would argue glycemic index, in my opinion, is a distraction most of the time. You want to know about a food that has a low glycemic index? High fructose corn syrup. Wow, that's great.
Would you guys talk about just a second about CGM? Because I see that often in my practice now, and people love information. It's continuous glucose monitoring. Those little CGM devices that are now readily accessible to everyone didn't used to be. They were medically prescribed before. I see them often come up in the practice. People are fascinated by the information they receive. And information is power. It helps people make good decisions. But I know Miles' opinion. But I would love to hear you guys talk about that a little bit. I've heard you talk about people get overwhelmed by the information and then just get hyper vigilant about it. So would you? I would love to hear.
Yeah, no, that's great. I mean, I have a skewed view because I'm seeing mostly patients with type 1 diabetes, and most of the patients I would see with type 2 are often more advanced. And so they are continuous glucose monitoring, or as a device you can wear on your body that measures your blood sugar continuously, and then it sends that information to a reader or an app on your phone, and then you can see it. So there's, like with everything, there's pluses and minuses for sure. So they can provide a lot of information, because sometimes what people think is helping them out in the long run maybe isn't, and then they have these surprise foods that they don't realize, like how high they go up and then how long they stay up before they come back down again. So I think it is a useful tool. There's certainly room for overinterpretation and misinterpretation of the data, which is what I think, especially people who don't have diabetes. I'm not a fan of wearing them, endurance athletes wearing them. I don't know what information you would get from that. I'm an endurance athlete. I would never promote that. So I think there's a lot of room for overinterpretation and then worrying too much about just normal human physiology and variability that is just normal. And then if you see it and it's a data point, then you think it's something that you have to respond to. So it's over-medicalizing, I think, often.
Shelley, this lady here has been...
Yeah, this question should be really important.
It better be.
I just had a question for Kayla. So the whole culinary medicine is so interesting to me, and I'm just wondering, with that dietitian arm and the classes, do they have to be referred by a dietitian?
So the question's about how do people get to see a dietitian out of the kitchen? Do you need a referral? Is that right?
Need a referral and then to just go to the classes.
Yeah. Do you mind if I take the, I'm sorry, I totally sped through that part of my presentation. But yeah, so we are a medical-based referral system, which means typically MDs are referring to us to take the classes or see a dietitian individually. So yes, you do need a referral, and unfortunately you do need insurance, but we cover a lot of different insurances are covered by our services. So we are very unique though to Milwaukee. So even if you're being referred to maybe a dietitian here on the west side and you're working individually with them, that's totally fine. You can always take a class at the Teaching Kitchen, and we also offer virtual options as well.
So the Teaching Kitchen is a little bit separate and open to the general public?
No, the Teaching Kitchen is a medical referral-based system.
But it can come
Yeah.
from the dietitian.
Mm-hmm. Exactly. And PCP, so primary care physicians, other healthcare providers can also refer to our services. Yeah.
Kayla.
Hey.
You mentioned on your slide cooking utensils that are ADA or might help, especially older adults who are living by themselves and might have arthritis or a walker or other things that might make it more difficult. Can you speak more to that? What would be helpful in the kitchen to allow older adults more culinary success?
Yeah, so we use adaptable tools like certain knives that are smaller, they're a little bit easier to handle, they're not necessarily so heavy like a typical chef's knives. So we have those. Also trying to figure out ways that maybe you don't necessarily need to use a knife. So we will kind of look towards things that maybe are already chopped up or frozen veggies, for example, and really incorporate a lot more of those options in. Also using a peeler sometimes could be a little bit easier than a knife. So if you're chopping things or you're peeling like a carrot or something a little bit larger, not understanding that you don't necessarily need to use a knife for that. We are also ADA compliant in just how our facility is set up. So there's a lot of different tools that we kind of discuss when folks come in and they say, hey, like I just had a stroke and I can't open jars. Like what are some of the things that you guys are using, right? Or how can I maybe not necessarily use this chef's knife, but do you guys have another recommendation? One of the things I didn't mention is that our culinary classes are not only taught by dietitians, but also by a chef who is a fantastic resource when it comes to different ways that we can use different appliances in the kitchen. Yeah.
OTs are great about adaptive devices as well. So making handles larger, accommodating for people's, I have a big voice, so making utensils easier. A high stool in a kitchen is a fantastic adaptive device because people can't stand for a prolonged period of time. Of course, that could be one of the things they begin to measure. How long can I stand at the kitchen? Back pain is a huge thing when you're standing, and so learning how to stand correctly or putting one foot up. It's all those biomechanical assessments and there's lots of adaptations for that, but yeah.
Gentleman in the back.
Yeah, you developed quite a multidisciplinary team and approach, but one of the things you bring up frequently is about the importance of mental health. When do you add a mental health clinician? Who do you add? How does it work on the team? And what kind of results do you get?
I had a question about mental health. Who wants to take that one? And do you see any improvements in mental health with lifestyle approaches?
So I think the biggest tool to help mental health is actually lifestyle. I think that's the first thing that we learned from the literature. The most successful treatment for depression, better food, exercise. And so the question is, where would so I would ask, I don't use mental health professionals in my practice. That may be an error on my part. I'm not saying it's the right way to do it, but I would ask that, you know, we would. So I don't know if anybody else here uses mental health in their practice for lifestyle medicine, but that's the question you'd ask: is what component has it been shown to help? I don't know if.
I mean, I work with behavioralists with certain patients. I mean, they're not in my clinic, but definitely if there's some value in assisting with like different mental health challenges. Also keeping in mind, you know, the what am I trying to say? The population in which we serve are typically high social needs, food insecurity, those types of things. And behavioral health has been instrumental in the work that we do. But I definitely agree with you, Miles, is yeah, when we change our dietary habits, we exercise more, we focus on these pillars of lifestyle medicine, we start to see these vast improvements in our mental health. It's like that cycle, right? So I think it really is on a case-by-case basis for most individuals.
Case by case, there's certainly times where I see somebody who's overtly depressed. They're in the middle of a major depressive episode, or they have really obvious ADHD. I'm not talking about a soft diagnosis, but really clear-cut ADHD. It's going to be hard to make some of those decisions and have optimal executive functioning if you're have competing, you know, pulls from a major depressive episode or untreated ADHD. So sometimes I think it really is absolutely necessary to address a mental health diagnosis before you can optimally try to make lifestyle changes. Yeah.
I would say you may not make those recommendations or referrals out, but you address stress, sleep, community, relationships, a lot of the components that are mental health related. You're addressing them within the confines of your practice. And yes, if they're pathological issues, then yeah.
Can you talk a little bit more about strategies for and how you talk to patients about deprescribing when they're already on medication?
Strategies for reducing their medication burden when they arrive on medications.
The first thing I say to them is, as you do this, your blood pressure might fall on your blood pressure medicines. You might faint, break your hip, or worse. So pay a lot of attention to your blood pressure. Secondly, if we're successful, your blood sugar will drop, and that'll increase your risk of a seizure that may occur at an inappropriate time. It may cause you to develop dementia at a later time. So watch your blood sugars extra carefully while you're doing all this.
Yeah, no, I agree with all of that. And I think there's a misconception too out there with diabetes that once you're on a medication, you're going to become dependent on it. You're never going to be able to come off of it. Unfortunately, that's often what does end up happening in reality. But if you're on medications and we're able to make a lot of healthy lifestyle changes, you certainly are able to step backwards and get off some medications. The pancreas works best when blood sugars are stable. So it's a little counterintuitive, but when your blood sugars are really high, the pancreas actually doesn't work as well. So as we get under better control and the blood sugars come down, if we've made some real underlying changes, that's when we are able to step back and come off of medications.
So I'm a Providence staffing nurse, and so I've been around the clinics for a bit, and I've noticed that it's kind of scary to think about. There is no consistency with like nurse education for diabetes. And a lot of clinics, they don't have any kind of materials at all for patients except for like the handouts you can find on Epic, which are really pathetic. And so I was wondering, I'm currently in Northeast Clinic, and I do have a copy of the food medicine, which is wonderful, but a lot of clinics don't. And is there like a very quick and dirty way that you find that nurses can be more helpful in your clinical setting to reach your patients more than just like, here's how you check this medication, or here's how you use your glucometer or something? Like, how would you use your nurses, utilize them more in your clinic setting, whether that's nurse visits or like flip visits where your nurse talks to the patient first before you walk in about their lifestyle and habits and stuff, because it's still not widely utilized.
So how can we use nurses in the clinics to address diabetes? That's a great question. So it takes a little bit of imagination and bravery and courage and exploration to find out what's your nursing practice going to be, and do you have support and teammates. So in my case, I just found some friends and said, how are you doing this and what seems to be working, and stumbled into Dr. Hassell's office and then came up with kind of a practice of my own. And so that's why we've built greatmed.org. It has evidence-based lifestyle guides for clinicians, so the nurse can go through and say, have these guys done their homework? Is this really a thing? Oh, last updated 2025. Looks like it's pretty current. And for every clinician guide, there's an evidence-based lifestyle guide patient handout. So the nurse can hand the patient a handout, tell them which podcast episode, 4 and 5 are pretty good ones for diabetes reversal, which podcast episode to listen to, and say, your doctor's going to be in a minute, and as soon as your doctor's done, I can spend a half hour with you. And so getting agency from your clinic to say, hey, can I spend some time with this patient after you see her? And for us, we tried the flip visits with a nurse first and then the provider second. And what we found was the patients wanted to stay and talk with the nurse a little longer. So we had the MA come in, do all the business stuff, have the doctor spend time with the patient, and then the nurses, people were generous with like the time they'd allow the nurses to spend with patients, and we just got to have a good time talking. And then just kind of opening up the barriers. We didn't realize like we could just invite patients to come in and get a weight check for free. That kind of thing. Like nurses can be just good connectors. They can be a bridge from the doctor to the patient and back and forth. And then that keeps the doctor on time, and it's least interruptive for a like big system medical model. But just come, like, call me. We'll talk. Yeah. Yes. What does follow-up look like? For our program, we were experimenting with one culinary medicine hands-on cooking intervention. And then the nurses would kind of like choose which patients were their favorite. And we'd kind of like create a little medical home for each patient. And they'd just kind of reach out. It just kind of happened naturally. Like, go with your gut and it's probably the right thing. And then what was hard was after their pregnancy episode, what does follow-up look like? We'd call them 2 weeks later, but they were released to their primary care physician. So there was a scary gap there, and we did see a lot of patients kind of fall off. So then, pointing that patient to a family member, or a champion, or a skinny friend who can help keep them on track. Dr. Duffins.
So motivation is an issue, talking about that, Miles, and pre-planning, certainly important. How would you suggest we think about starting the day with a plan? A plan for exercise, perhaps, walking, a mindset to start the day, and to kind of set the tone for the day for a lifestyle.
Good question about motivation from Dr. Duffins. How would you start the day from the moment you wake up? And then after this, we'll take one more question, and then those of us who can stay will stay and visit with you right up here. Come on.
I always turn it back to the patient that I'm talking with. What do you think is going to work best for you? So for some patients, starting the day with a time of intention, maybe some meditation, some journal writing down what they're grateful for, just something self-centering that's more cognitive. Sometimes that can be helpful for patients. For other patients, if they get up and they just start moving right away, that's what gets them going for the day. So I'm not sure, there's definitely not a one size fits all, but I think different ideas are all warranted, and just figuring out what's going to work best for you and what's going to stick.
Miles, what's your strategy?
One of the standard questions I ask is, what do you want life to look like in 5 years, 10 years, 15 years, 20 years, depending on their age? So I might ask a 40-year-old who's on blood pressure drugs, do you want, how vital do you want to be when you're 70, 80, 90? Do you want to be able to play with your grandchildren? Because you're already 15 pounds overweight and on blood pressure drugs, and these blood pressure drugs are going to do these harms, including increasing your risk of diabetes. And so I sort of paint a this is the bad cup thing, paint a picture of you've got a trajectory, and we actually have a little handout in our exam rooms where we paint two trajectories. A trajectory where you depend more on medicines, or a trajectory where you depend more on sensible decisions every day. And so if you want the sensible decisions every day direction, what are you going to have for breakfast today? What are you going to have for lunch? What are you going to have for dinner? Or I actually usually refer to the next day. And when are you going to fit in exercise? And I might actually pick up like a medicine ball in the office and start, while I'm talking to them, I might be lifting a weight or medicine ball, I'll say mean things to them like, how would a busy professional find time to exercise?
Don't do that if you have a rotator cuff
issue. Okay. I was going to tell you about my biceps tendonitis here. Well, did we answer Kurt's question?
Well, Diane, too, what ideas do you have?
Okay, I would say you start the night before. You prepare to prepare. And it could be, I have patients who, it's going to be, May next week, and they've already laid out their May calendar. And if they're athletes who have very specific training protocols, for me, it's my lifestyle, add exercise first, and then look at how are you going to layer everything else in. There's work in there, there's family in there, there's meal preparation in there, but preparing to prepare. And I do love Dr. Chatterjee's 5-minute 3 things in a day, and do something for your body, something for your mind, and something for your heart or soul. And if you hit all 3 of those categories, you put them in wherever they want. I don't think it needs to be first, second, or third, but 1 mouse bite of each thing every day.
Oh, I just wanted to tag into that. I'm from an outpatient background. But for myself, I say, how will I define success today?
Question, how do I define success today? And these are the things that we were missing when we met patients in women's health. We weren't asking, what are you eating? What does success look like? What do you want your birth to look like? What do you want life to look like in 5 or 10 years? So we want to thank you all so much for coming. Stick around, let's talk some more. Call us, send us a text. We're on all these social media places. And thank you so much.